those who are sitting around the table, but any members of the public who are joining us live on the live stream. Yesterday, the second Shadow Board was held, and as on the previous occasion, Mr. Crowder, who chaired that meeting, will come in with views from the Shadow Board at relevant parts of the agenda. I want to emphasise too that in order that we get through the business in a timely manner, that our intention is to finish at 1:45. And so what I'm going to do is allow approximately 15 minutes focus on each agenda item. That means that we have to assume that all papers have been read, and that I'll go straight into questions from colleagues. It's Wednesday, so feature of Wednesday is the Bible. So just be aware of that, though I don't think we'd forget it, would we? And just to remind ourselves that the elections are coming up, and so we are in Herder. So we have to remember that it's inappropriate to make any references to matters which might be seen as part of political. We have got a change for the patient's story. Unfortunately, the person who was going to share her story with us is poorly. However, just like you, Peter, there is something that we've got in hand. So could I turn to Professor Caudle to introduce this?
You can. So thank you, Chair, and thanks for everyone's understanding that about the change in order. What we thought we'd do is set the tone for the meeting in reference to the presentation that we have later on from colleagues around the discharge integration front runner. I'm so sorry, my mic on. And we have a video of colleagues who are in our nursing team looking after patients and carers, patients with dementia and their carers. So I will hand over to Jude.
Thanks, Heather. Morning, everybody. We've got colleagues coming later on this morning. We're going to play this video at the start of that conversation. But this is just a 2-minute video that really is the voice of our staff and our populations in our communities, and talks to some of the work and the tests of change that our teams have been doing as part of the Days Kept Away from Home project and the dementia project. So tissues at because it's 2 minutes to talk about change. Thanks.
Front-runner team looked at early supported discharge for patients living with dementia, and then people that are in crisis in the community where we can input and support to keep people in their own homes. And we have supported A&E patients back into the community. On the day, within an hour, we've been able to support them home and then look at that ongoing care and support in the community. And a strong feeling is getting people all, I think they should be in their own homes. I'm proud of it because
everyone's been a success. They feel supported from it. It's just one thing that they're missing out to that care. They just needed somebody there to say, I'll support you, I'll come over with you, if you need me, ring me. Yeah, it feels good, it feels rewarding. Somebody with Alzheimer's, full-time, 24/7, on your own, really hard. I think his team kicked in and the help was, it was there. It was just there. It just appeared. Like magic, like angels. And they'll come to help us. He goes to Bluebell Daycare twice a week, which is a godsend. And he absolutely loves it. Because he needs to get out of the house, he needs to meet other people. And by the time 3 o'clock comes and he comes home, I'm ready to fight again.
I think it's the holding of the hands really, and to make sure that people have got the support that they need in the community. And I think daycare and the services that Age UK provide do absolutely keep people in the community and out of hospital. Been really successful because it's supported early discharges from the acute beds and referring through to the front room, so we're stopping that hospital admission altogether.
Thank you for that presentation. Can we continue then with apologies for absence?
And Chairman, we have apologies for non-exec director Rachel Jones.
Thank you. Are there any declarations of interest that colleagues need to declare? If not, let's move on to the minutes of the previous meeting. That's from 6th of March. Can we accept those as a correct record? Let's turn then to matters arising from that from that board meeting. Are there any matters that colleagues would wish to bring to the table which are not on the document before you? If not, shall we continue then with the action tracker?
Apologies, Chair. I've missed the correction for minutes. There's just a couple of points. Last time's minutes, apologies. There's just two numbers in the report that are repeated throughout. So I think it's just, there's only 2 errors, but they're repeated. There's one on the deficit value in the minutes. It states 90.2 million deficit. That just needs amended to 90.8 million deficit, and I'll work with Jane to correct that throughout the document. And equally, we make reference to cost efficiencies in the paper, and we talk to a value of circa 70 million, which is language that was used in the meeting. But the reference to the accurate figure was made also in the meeting of 76.7 million. So I'll just work with Jane on correcting that throughout the minutes as well. So it's just the 2 numbers, Chair, but they just need correcting at multiple times in the document.
Thank you very much. Can we continue then with the action tracker? And are there any questions colleagues have about that? Just the Caudle.
Thanks, Chair. Just to update the board that we have received the final report from the LMNS regarding their assurance visit. It came at 5:01 yesterday, so that will form part of the perinatal formal paper next board meeting. But we have received it just to update action.
Thank you. Can we accept that paper as it is with the updates? Thank you. let's turn then to the finance report. Mr. Crowther, sorry, Mr. Crowther.
Probably.
I'm getting my consonants mixed up.
Okay, thanks. So yeah, we've got the AAA report there. We're going to come on to a moment to the detailed report on month 11. So clearly those issues are contained within the alert section. The key issue around being on track for most likely forecast position, and also in the alert you can see the increased focus of the Finance Committee on tracking the cash position as well. In terms of, just to flag up in terms of the advisory section, speed on business case protocol, which the committee has sent back for further work. The electronic patient record system business case is also worth flagging. Touched the Finance Committee for the first time at that meeting to look at the broad process around the journey of the EPR business case back to the next Finance Committee and to the board. So that we understood that, but clearly the Finance Committee will be looking at affordability in more detail at the next time that comes to them. And also, which we'll be picking up in part two, there has been an extraordinary Finance Committee meeting where further scrutiny has been placed upon the gap in the 24-25 SIP programme, and we'll talk later with regard to that. Probably only worth flagging up, I mean, the paper we're going to look at next did go with the shadow board yesterday. Good discussion there. Probably the useful items for flag here is at the shadow board, there was a more detailed discussion about the achievements through the grip and control, but also some of the unintended consequences that are felt on the ground with regard to that. Examples being with operating department staff with agency rates cut, that can be doctors, anaesthetists, teams not being paid and not ready to go. So I think as we get into the business as usual embedding of grip and control, which we've talked about here, utilising some of that insight and knowledge around some of those unintended consequences and costs of kind of the blunt instrument of grip and control will be part of the 24-25 discussions. And also at yesterday's shadow board, a good discussion around flexing staff. So again, on the cost improvement part, flexing staff across the care organisation. So a lot of insight from that level of leadership with regard to opportunities in terms of deploying staff across the organisation that I think would be of value to us listening to. So but certainly happy to take any questions on the AAA report itself.
Colleagues, are there any questions on that? If not, could we turn then to the month 11 update on finances?
So, Chair, as discussed at the beginning, assuming colleagues have read the paper, I just want to pull out some salient points just for the update for board today. We are reporting a deficit position of 68 million. That's against the current month 11 position. Obviously, we're now working to year-end position as we sit here today. That will lead to ultimately a 72.7 million outturn deficit for the trust. Now, what I've said to the board in the previous month is that includes the impact of industrial action of £6 million. So the intention is to finalise the funding arrangements for the industrial action of the £6 million. And if we receive that in full, we land at 66.7 million deficit as discussed in earlier board meetings. If it doesn't arrive in full, we need to understand the impact on that position. So if there's any shortfalls, it will be between the 66.7 and 72.7. I'm going to make that clear for board by 12th position. We are on track, therefore, for all the deliverables we said around grip control, CIP, any planned delays on GMMTH and our income position, which is good news and means that we have been able to commit to the GM turnaround team that we can hit the forecast outturn that we agreed with them, pending the resolution of industrial action, which is outside of the scope of those discussions for the GM turnaround team. In terms of capital, we, as reported at the last times board, have been tracking spend to the tune of the 73.2 million. And we are confident that we will spend that in full, given the latest update 24 hours ago. So we will satisfy our capital expenditure requirements and we'll have spent what we have been given to spend in full, which is good news. We've been able to do that through lots of hard work with the states and facilities teams and all the care organisation directors have been working really hard to make sure that we can get those delivered and spent this financial year. The cash position is relatively healthy at this stage. We have 146 million reported in this report, and that will deteriorate in month 12 as we spend the capital, but it will still be above the 10 working days threshold in terms of any sensitivities where you might start to alert board to a cash situation. In terms of the forward plan, Chair, there is some reference in there that we'll pick up in part 2 around the CIP plan for 24-25. We know that we're working towards a target of 76.7 million at this moment in time, and we are working on closing that gap at the minute. And in the paper, it makes reference to what's currently identified, which is around 46.5 million if you do not risk adjust for that figure. So we'll pick that up in part 2, as well as the overall position for GM on 24-25 planning. But that's all I need to say on that for now.
Thank you. Questions from colleagues? Oh, no, I don't need to press anything. Red means that you can speak.
Okay, so not a question. I think I just wanted to say well done to the executive team for delivering the turnaround plan. I mean, obviously it's not ideal, but you know, it's been a tough job, hasn't it? And to keep that impetus up and deliver what we said we'd deliver, and I'm sure that must have helped us gain some credibility with the turnaround team of the NCB. So that was just to pass on my congratulations.
I'm sure that we would all support that, especially those of us who've been to the turnaround meeting. Mr. Rashid.
Yeah. I mean, I echo that. I know it's been a really, really tough time for everyone at the Trust. My question was about some of the grip and control measures, and when I read this report, there were some big anomalies in terms of different care organisations, and looking at slide 8 out of 32, Bury has a reduction of 997,000 from an average monthly spend of 2.1 million. That's a 50% reduction in those that are covered by grip and control measures. Oldham was 17% and Salford was 11%. So Salford was saving £500,000 at 4.6 million average monthly income for 3 months. So my question is, how are we applying grip and control consistently? Are we applying grip and control consistently across the organisation? And if we are, does that mean in the past, Bury spending was out of control and Salford spending was really brilliant, so they only managed to save 11%? Or does it mean that Bury have worked really, really hard and what are the consequences there, and Salford have been really cautious, worrying about the unintended consequences? This might be one for other, chief medical officer and chief nurse as well, actually, because that's a huge disparity, isn't it? A 50% saving on those, and then an 11% in Bury, and an 11% saving in Salford. That's, if we want to save more money, that's what we should be looking at, shouldn't we?
I think, are you referring to page 8, did you say? Sorry.
Slide 8 out of
Slide 8,
22.
yeah. So I see the larger gains, if you will, on the Bury position being the agency, not the bank. There's 812,000 on average reduction on agency. And I think, that'll be, I always attribute this work to the work that Heather has been doing with the nursing team. And making sure that we triangulate that. We've got a paper on the Safer Nursing Care tool later on in board meeting. So I think to answer your question, are we paying attention to, as Tim alluded to before, the impact of this? And the answer is undoubtedly yes, because we are backing that up with safety assessments, and we're backing it up with asking how that is sustainable in establishments. In the paper you'll see later on at board. I do think it is more around the use of agency for Bury, where they've had some major successes, and you can see that in the report. And that will be triangulated to some increase in substantive costs, which you can't see in the full scheme of things, and perhaps not as reduced bank spend as a result of some of the agencies been translated into bank. So I think we can get some more detail, Aziz, but what has been really insightful as part of this work is when we've been looking at the 24-25 plans, and we've been looking at setting establishments correctly with the Safety Nursing Care tool, and with the taking into consideration what we're currently spending and what we need to spend going forward in established posts. And that does take into consideration any impact we may have had on grip and control measures, because we take into consideration those areas where we have reduced spend, and whether that is now, when we run it through the safety checks, sustainable from a recurrent point of view. So I think I'm satisfied from our process point of view that we picked it up across those points, but I'm sure Heather will describe it more eloquently than I have.
Yes, Gordon.
Well, actually, I was about to say I don't need to say any more. I think you've covered it all, really. That it will be okay. If I have to say anything, is to address the question within your question, which is the variation warranted or unwarranted? Is it about people not having the attention before the impact, and people are being unfairly or in the lack of parity? What I will say is that we're still finding out those questions. It is a continuous improvement and continuous inquiry, and the approach to these to the grip and control is collective leadership. Colleagues attribute these successes to SROs, but how we've approached this, I think it's been different to how we've approached it in the past. It is a triumvirate, a financial triumvirate, I call it. It's the Director of Nursing, the Director of People, and the Director of Finance working together to tell me what their trajectories are and what they're doing to deliver it. My input in that is to have the data to underpin the conversations and to provide the challenge if the stretch isn't good enough. We heard from Tim in the shadow board the unintended consequences of the grip and control. What I would add to that is a bit of a caveat around recruitment planning. The conditions of some of the control measures is that colleagues do two things. They provide a recruitment plan to address the vacancy gaps that are driving the agency usage, and they give a heads up ahead of the period at which we apply escalated rates, and those escalated rates would be coming to an end. We want a heads up that those plans or those trajectories aren't being met. In the cases I think that people are referring to about unintended consequences, recruitment plans were delivered, and the heads up was given enough in advance. We were told at the day that the rates were being reduced that we wouldn't have any staff. So that to me is it's learning for us. We've revealed a gap in terms of recruitment planning, and we've revealed a gap in perhaps psychological safety to say to us, this is what we need. We need the rates a bit sooner and to focus on business continuity, etc. So I think it's exciting, and I think that the difference is information, but it's not showing us anything that we should be worried about, because that group is actually a place where people are discovering and learning new skills and strengthening their governance around some of the financial management around workforce.
Thank you.
Do you want to add anything to?
So my only observation is certainly, if we go back about 18 months, Bury were disproportionately spending on agency in terms of their temporary staffing. So if you look at their month 1 to 4 average for agency, which was 870 compared to Salford, which was 933, in terms of the size of their organisations, the proportion of their spend on agency was much higher. So it doesn't surprise me that we've seen a bigger reduction for them on that agency, because they have further to go.
Just to back up what Nikki is saying, what we've discovered in that meeting is the risk appetite around agency use has changed with the director of nursing. So the recognition that the quality will be affected was something that we helped drive the reduction in agency.
Thank you for that. If I can just bring this together, because I think what we've seen is how that relationship between nursing, finance and people are actually being focused upon when addressing this question of unwarranted variation. And then, importantly, it's based upon the use of data. So I think we've had a really good indication of how using data and working collaboratively across that senior leadership team actually has some positive consequences. So thank you for that question, stimulating that conversation. Thank you. But let's move on then to quality and performance. Professor Shaw, would you like to start with the triple A?
Thank you, Chair. So, as you can see, the QPC committee members have had a very comprehensive and detailed discussion based on a number of areas highlighted in the summary reports, particularly around workforce retention within public services, aligning with the detailed maternity service report, which we'll mention later, in the context of reduction in life leave commencing compared to the previous year. We did focus on some areas which I will bring to your attention in a moment, but there are other matters which will be addressed in the reports that follow my summary of what we discussed. That's the maternity services risk identified and data points and the nursing establishment review. For those areas of further noting and consideration by board colleagues, I would suggest that we do pay particular attention to the doctor contract expiry challenges at Panda units. I'm sure everybody is familiar with the challenges that I am addressing, but it does pose a significant operational risk, particularly for mothers and their children coming into Panda unit expecting to be seen and to be managed appropriately with the relevant care. So that is a red flag that I'd like to just highlight. The compliance with the thorough inquiry is another one. So we had awaited on 2 occasions reports and updates on how we're going to respond to that as a board, because we need to understand what are the recommendations and how they will be implemented within NHS itself. We have requested an update regarding that, particularly the questionnaire related to the trial, and I know that Dr. Vanessa is going to address that at the next meeting of the QPC. We received a very comprehensive and very interesting report from the annual infection prevention and control report which again was extremely insightful in many ways, but we did pose the challenge back around the increased risk in C. difficile infection rates. So we have asked for a close examination of what's the cause and effect of that and how that's going to be managed within the NCA policy on infection prevention and control. And can we have an update particularly on this matter regarding antibiotic prescribing practices in both hospital and community settings? Nursing establishment review outcomes are going to be discussed later on, so I'm going to pause at this point. But I will conclude, sorry, on the urgent and emergency care performance. Despite challenges in meeting the 76% target for urgent and emergency care, efforts are underway to achieve 70%. The board should continue to closely monitor the effectiveness of our operational improvements and test of change we implemented to enhance our service. I'll conclude there, taking questions if that's required.
If there are no questions, Dr.
Thank you, Chair. I just wanted to excuse me. I just wanted to add a bit of clarity around specifically the throat issue. So, just for the avoidance of doubt, we received a questionnaire from the Throat Ward Quality Inquiry, which has been completed and submitted within time. What we're now seeking to do is just provide additional reassurance to the board in terms of any additional actions that we think we should be taking within the organisation. And so that's what's pending that we will bring back to QPC. So I just wanted to add a bit of clarity there. Thank you.
Thank you. Ms. Clark?
Yeah, I'm pretty sure this is right, but under performance delivery on the elective recovery, it says commitment was made at the Finance Committee that contract rules would be made to LLPs that were not on the framework. I assume we mean wouldn't. I'll just check that and make sure that the paper's updated. I don't think we want it confirmed. Give them to LLPs who weren't on the framework. I assume that's right.
That's right.
Yeah.
Thank you. Finally, Mr. Little.
Thanks, Chair. The doctor contract wasn't clear from the report what the solution is, because I've not seen this come through to the Finance Committee as an issue. And also on the handler unit, I note that the committee is going to receive the results of an external review. But is there a need for any more urgent action given the current operational problems and the increase in pay to the end of March?
Mrs. Adams?
Yeah.
Respond to.
Yeah, thank you. Just in relation to the doctor-doctor contract, Jeff, it is in the current run rate. So it's in the outturn position of the organisation. This was about renewing the contract. And so I'll use Lorna's language in some of this. Lorna has a number of federal systems that she is trying to gather up and align to a very clear digital strategy. The doctor-doctor contract is one of those. However, the benefits of that in terms of our ambition to do a digital first contract, in terms of trying to do a digital first contact with our patients, text reminders about their appointments, the drive to bring the DNA rates down, the benefits of that contract, we fully understand. So it was discussed at the senior leadership team meeting. Craig and the finance team have picked it up in terms of the outturn and the continuing engagement with Dr. I think, interestingly, just having some conversations with Katie this morning, there are some things within that contract about reports that we would expect from them that will help us continually drive our performance that I think have dropped off in the latter part of the year. So I think it's within the current financial position of the organisation, and we do need to continue to drive that digital first, because otherwise we are into people doing things and bringing patients. So hopefully that answers your question.
Thank you, Chair. So, first of all, in respect to the advice, there's a point that relates to the NCA-wide mock inspections being undertaken February 2024, and the language that's used that kind of indicates that we're not where we should be. And I guess Heather and Vika, that's a question about what do we need to do to make sure that if you think about the anniversary of when the CQC came, which would be August 2024, what are we going to do so that we would have a different readout from the Quality and Performance Committee, as said here. And then one's just a factual point that this talks about. There's hard work going on to achieve 70%. We'll find out later that we haven't achieved 70%. So again, I think it's just something there. That's more of a how do we, in terms of what we report and actually what we discuss in this meeting. But I think the first point is I don't think we can be comfortable as a board with. Certainly, I'm not comfortable with what that narrative is there from the mock inspection and what it describes. So I just welcome thoughts from everyone who can describe it.
Thank you, Chair. Just to let the board know that the detailed outcomes of the mock inspection will be presented at QPC in April and will come to board next month. What I can say is the main outcomes which drive that statement is the variation across the organisation still. We have tried one major exercise in the CQC improvement plan was the harmonisation of policies. Whilst we've gone some way to get there and we're making good progress, we will still have some policies out of that harmonisation window to date, mainly from the diagnostic and pharmacy care, and that's because it does span across the organisation, and getting a consensus as to what that would look like has been quite a challenge. That is a theme throughout the feedback, where we have meetings that occur in each care org, it occurs. So the level of variation is what is driving some of this. And I think that in part, in answer to your question, Owen, how will we achieve that? I think that the clinically led model will help in some way to achieve that standardisation, because we will soften the silos at the moment that exist within care org. The other major driver to that statement of things that aren't where we need them to be is around our ability to adhere to guidance around mundane and basic tasks. So, for example, we now know that we scored 54% of compliance around medical fridge temperatures and a less percentage on catering fridge temperatures. So checking fridges on a daily basis is something that we're not able to do. Resus trolley checks as well. We're failing to hit 100%. We are in the upper 80s, but we need to have, from that inspection, we demonstrated we only hit as a trust around 85, 87%. In response to that, the directors of nursing have strengthened their assurance processes and receive a weekly sit rep of research trolley daily checks. But that is something that we're coming up against a real cultural resistance almost to doing mundane tasks. How we get there, I think, is around a grip and control almost approach to this. It is basic stuff that we are falling at the hurdles on this. What we are, the positives are mandatory training levels are up. Safety huddles are something that we seem to be consistently performing 100% at. But again, the fragmentation of the trust is revealed when asked a question, what are our values? People didn't seem to know it. We're seeing some interesting contrasts between the feedback on some of the people measures in relation to the staff survey. Well, one hypothesis is that the mock inspection actually is targeted at a different staff group to ones that perhaps are responding to the staff survey. So we have a long way to go in terms of, I would say, addressing some of the mundane, the basics, getting that right, but also the lack of consistency and harmonisation across the organisation.
If you don't mind, the mic on. I don't think we've got that time. So I think, you know, we need to be thinking about how we accelerate so the hypothesis, the reasons given for the why not reasonable, but it'll be 2 years. And I think quite reasonably we should be expected to be in a better place. So maybe we need to pick that up. So I think.
So yeah, so we've asked the medical directors to help with the mock inspection the last time, because another thing that was discovered in the acute settings, no doctors were spoken to because apparently they were busy. I don't think that was the reason. I think it was something about medical engagement or doctors being on the inspection group as well. So we've not really hit the mark in terms of engagement and getting the right leadership attention on this. So I think the group met either yesterday or will be meeting this week to see how they will be involved moving forward.
Thank you. So I think Heather's covered a lot of what I wanted to say as well, but for me, there is something about back to basics. There's something about harmonisation. Your point about timeline, doing one going. Obviously, we can't wait until sort of full clinical leadership model rollout for us to be expecting to see these changes. But in the same way as we're trying to explore how to accelerate some elements of a future clinically led model, I think this fits into that and would more or less fit with the timescale that you're describing of August 2020. Let's call it August to October in terms of harmonizing some of our meetings and structures across the organization to make sure that we don't have that variation. And the final point that Heather brought up, we have had a discussion around increased medical involvement in the inspections and using that as a lever for further engagement. So, if there isn't anything else on this particular point, I'm just conscious that Jeff asked us about Panda, and I wanted to circle back to that. I address that now. Yeah. So I just want to say that the Panda issue is a complex one. We are wrapping around some robust business continuity arrangements around this. I think it'll take us a little while to ensure that we have stability. So we need to just safety net that as an initial phase. The that's referred to is now organised. Heather can update us at some point as to what sort of timescales we're looking at. But ultimately, there's something about how the Panda unit sits within a wider NCA context of delivering children's services and how we ensure that everything is appropriately networked so we have the appropriate resilience across the organisation.
Thank you.
Thank you. So, great with the response on the Panda unit. I want to get back to the conversation about the mock inspection, and I very much support the chief executives. Of course, put urgency on this. That's absolutely right. I think from my perspective, though, in addition to that, when we get the reports back next time via the Quality Performance Committee, I'd welcome a real focus on this question of lack of consistency across the organisation. I can see that the clinically led model will be a very positive force good in countering that lack of consistency. But at the same time, I'd like to understand what the consequential implications are for the care organisation structure of the organisation and what will become of that. and the financial implications of that question. I mean, the final part of the jigsaw for me is then consequential implications of any changes to the care organisation structure on our relation to the 4 locality partnerships and how we get as much as we can out of those locality partnerships and in a way that's visible here at the board. So if that's not putting too much onto that report about the mock inspection, I'd be happy with those issues to come forward in separate reports. But I do see those 3 things linked to consistency, clinical-led model, the care organisations, and consequently what we do about locality partnerships.
Thank you. I mean, I do think I take the relevance of the point you're making, but I think, you know, time is not on our side, and I think the really important thing is to identify some of those basics, which, I mean, for instance, temperatures of fridges, you know, which would be helpful to know how come that is the case. What is it about? Lack of staff, lack of opportunity to make it part of the routine of the day. But I think we do have to focus on identifying, really stratifying, prioritising which of those back to basics can be done sooner rather than later. Sorry.
Oh,
well.
Yourself.
Do you want to go, Heather? Okay, so I was going to talk about the panda issue, unless you want to talk about the
No, that's fine.
mock inspection. So just in answer to your question around what is being done ahead of that, there is a 4-point action plan that's being reviewed weekly by Charlotte Bailey, who's the Chief Officer at Salford Care Org, and that is updated and it covers workforce issues, issues of safety, recruitment, etc., and the external medical reviews. So that's being monitored by Charlotte, and Jackie Burrows attends on my behalf. The business continuity was mentioned by Rafiq about Alan Caldwell has helped the team come up with a business continuity plan to address gaps in the senior staffing rota. Charlie McGibney, who is the Director for Urgent and Emergency Care Improvement, has also been working with the operational triumvirate, so the Divisional Director of Nursing, the Operations Manager, and the Clinical Director, to work with the 3 of them to come up with a composite plan around the short-term, medium-term and long-term plans for Panda. And a forensic review of risk has been carried out as a result of that. All of this will be coming to QPC, but the headline to that is, from a business continuity point of view, the services at Oldham, our paediatric services, are on hand to give any support from a senior medical input. We have a consultant on call at night, which is where the gaps seem to be predominantly coming up, and that person is on hand and trained and prepared to deal with sick children as and when needed. And the issue of a general review of the safety of the unit, that's being conducted by Dr. Vicky Jones, who is the medical director at North Middlesex Hospital in London and is a paediatrician. And that is due to take place provisionally on the 11th of April. So we've got a date for that to happen. So there are some short-term, medium-term and some longer-term plans around the Panda unit. But at this point in time, the issues of safety, we are ensuring that the unit isn't subject to treat and transfer measures. In terms of, I would say, the immediate risk to children, the report will reveal the details, but we are sufficiently covered medically on the Salford site, and if need be, with some planning from other sites in the NCA to address those gaps. And we are monitoring closely and working.
Thank you. Thank you, Mrs. Mayor. Sharp touching. I think maternity is a good example of where we've had such high level focus on improvement, but we've not paid attention to the detail. And the risk report that came out on maternity is a similar point here. I think we've been referring to about not having an eye for the detail. I think that's something we really need to. I don't like using going back to basics, especially. It sounds so political, but we really do need to think about that. I wanted to ask a question about AMU2 in Oldham. I went on a visit to say thank you back to the staff that set it up very quickly and very successfully, but sadly came to a conclusion a couple of weeks later. And I think it's because of the pressures on beds and pressures on accommodation that needed to be reallocated to urology because of the disaggregation. So I think the question really is about strategically, what did we learn from that? What was the impact on A&E and what can we do in the future? The staff there were very proud of what they've achieved, and I think we're very keen to be able to maintain that service, but for it's a very difficult balance, I know that, but did we learn something about this? Is there something we can do in the future? Mrs. Adam.
Thanks, Chris. So we just finalised all the scores on the doors for March, but certainly those extra acute medical beds in Oldham have helped them undoubtedly through the March position. And we know from benchmarking data that acute beds in Oldham are lower for the population, and they perform fairly well on patients with no criteria to reside and their length of stay, with a couple of exceptions in two specialties. There is a live conversation between Craig and David Jago and I, because the teams that opened those beds for our March position did so using their SPA time, the medical staff coming in on their annual leave to provide cover. So absolutely went above and beyond, and we should recognise that here. Craig and I have had a conversation with David about, if we think about all the money that we are spending on urgent and emergency care, where should we be putting it? We do post-project evaluations as a sort of example. Where are we getting best bang for our buck in terms of resources? So if I think about some of the frailty work we're doing lots of things in different spaces. If I think about the funding that we've had for virtual wards, are we really getting the benefit in terms of 4-hour performance from investing in virtual wards, or actually is our population mean telling us that a short stay is really where we can gain benefit? So I'm not always a fan of putting beds in, because I think sometimes it doesn't allow you to think differently, as we saw in the patient story today about caring for people at home. But there is definitely an underlying deficit in my mind in Oldham, and I think our Reese's colleagues that work with us and would recognise that too. So Craig and I have given David some suggestions about actually where we might recycle some of the money that we are spending currently. You know, we're spending a lot of money on outlier doctors. Well, actually, can we bring those back in and fund those beds in a more sustainable way? So those beds haven't closed as of today because of the weekend. It's pretty difficult, actually. But David is working at that business case, and the teams have got ideas about where money is being spent and where we might better spend it in order to give us the improved performance that we need going forward.
Just one more comment, and then we really must move on. Professor Sharp.
So mine's an overall comment based on what I've heard from colleagues this morning. And there's 2 points I want to make. One is that the QPC agenda is massive. It's very intensive. It captures and has to capture and has to give interrogation to very high level quality of care, patient safety, quality improvement, patient overall care issues. The conversation we just had around CQC, we're very mindful of. And one of the unfortunate examples today of this report is that it doesn't fully illustrate what we as the QPC, who need 3 hours and sometimes have to go on longer because of the substantive nature of the discussion we're having. I think it's very important in priority areas, is that we do have line of sight. We are focused, we are seeking assurance, we are challenging our executive colleagues, and we want to understand where there is inconsistency in our performance measures or within our the patient experience or outcomes for those patients across the NCA, across all our care organisations. We want to see evidence of how change is going to emerge from the implementation plans that we discussed and are shared with us. And we come back to the point always, and I'm sure colleagues from the QPC committee will appreciate what I'm going to say. We must continue to emphasise that evidence of the effectiveness of improvements from those implementation plans needs to be more readily available and needs to be more timely presented to us at QPC in order for the board to have the further assurance it requires to ensure that we remain on track. And so, to your comment, Jeff, and to your chief executive, we are already on the case with those items. So these are not minutes that you see. So it's very hard to convey actually what we discussed in detail. And I think there's some learning from us and an important place to pause when we consider how each of the committees work and how we can be more effective in that working relationship to ensure that we are aligned and have shared line of sight about our assurance collectively as a board to understand whether what we have in place and what we discussed is truly giving value and presenting a positive, robust response to the quality of care challenge, to the financial sustainability plan that underpins it, because we need that to be aligned to, and overall to make sure we do enhance, improve and continue to extend the patient outcomes in a positive manner. So I just felt I wanted to say that because it seems to be a continued theme from conversations when we have the QPC summary reports. It always ends up with a much larger discussion, and I think that's.
Thank you for that. I think we need to take that offline. So can we move on then and continue with the maternity services report? Professor Caudle, are you going to?
Thank you, Chair. I'd like to invite colleagues from the Perinatal Division to present the report as per our how we present the reports all straight from the operational, clinical and maternity leads. But you're on your own today.
I'm on my own, so I do apologise.
So can we go straight into questions from colleagues, please? Lee? Ms. Clark.
In the absence of any questions, I just wanted to say well done on the incident backlog. Really good.
Yeah, I'll take that back. Thank you.
Really interesting source of assurance that given that focus on governance, it is actually reaping benefits. So thank you.
One, you might be able to answer this, Andrew. There's the detail on the exit interviews for midwives, and the majority of the leavers are going to other trusts. I didn't know whether we've done any digging underneath that to sort of understand why and what the attraction of other trusts is, or the not attraction of staying here is.
So what we've seen, so we have got retention midwife in post now, which we are seeing the benefits of that in terms of the communication with staff. I think so. In 2024 January, we saw a significant reduction in those leavers. So we had seen a 75% reduction there, which is positive. So those retention conversations, exit interviews are continuing to take place. So obviously, as we progress forwards, we'll be able to learn from any of the feedback received.
Mrs. Drinkwater.
Just to build on the congratulations on the progress made, it's fabulous. The report refers to the governance team giving assurance that there will be no overdue SI actions by the end of March. Did we get there?
No. So I know in the report the figures actually written in the report, they have actually improved on that, but we still do have. I think there was 8 overdue actions still remaining, so they are being worked on. And we have actually got 2 outstanding incidents as well, which are being reviewed. They expired. One went overdue at the end of March, and one was sent out for external review. Hence, it's reached its time frame.
Okay, still good progress, and I think that's great. Do you think the team were being a bit over ambitious?
Yeah, I think they really felt they could achieve it, but unfortunately circumstances have not allowed that to happen. But work still continues, and they have made great progress. So it's a positive step forward, and that will continue.
Thank you.
Mr. Crowley.
Thank you, Chair. Yeah, it's probably the feedback. This was one that we had a shadow board yesterday, and this is one of the papers they looked at, and kind of I guess what some of the discussion was around the antenatal deep dive.
Yes.
I suppose firstly, why we needed a deep dive to kind of reveal these issues, so the extent that we knew these before, but also there was some challenge, particularly around the robustness of the action plan. A lot of the dates kind of passed, some of them are delayed. The issue is in respect to the finding or documentation, seen as kind of quite a critical issue, but not really picked up in the action plan. So it's kind of a general issue. Was the deep dive presenting us with something that was a surprise, more particularly your view on the robustness of the action plan and the leadership attention it's getting?
So this is being picked up as business as usual. So I think you're correct in terms of the action plan, and there's further work to be done on that. I think what we did identify, and there were multifactorial issues in relation to some of the things we've been seeing with antenatal clinics and the impact it's having on one, the demand on the service, and with our overrunning of clinics. So excuse me. There are a multitude of issues which we're trying to address, and some of them are working with in collaboration with other areas. So we've got radiology issues, booking processes, plus documentation, which you've quite rightly picked up. So those actions in the action plan were to address some of those process issues. I think what we need to now focus on is some of the actual documentation issues as well, and that action plan will continue to be reviewed as well.
Yeah, but I think with being this kind of permission, that I think having that spotlight on that action plan will be a kind of helpful at QPC. That's okay.
You probably asked for that. That's
Yeah.
we must understand that to it.
Yeah.
Deviations. I was going to ask you a follow-up question on that one. In the same way, we've asked for an update on the maternity triage risk and estates challenges. So again, it comes back to the point I made earlier. So the substances and the really important issues at the front door are.
Yeah, and I agree with that absolutely. I think getting that that shared scrutiny, it's not just at QPC, it's at QMEG and other committees that sit beneath that. I think that collective kind of understanding of that. I guess this is putting a particular spotlight on the documentation element of that action plan as well, which we can add to the QPC focus. Okay.
Mrs. Mayor?
Thank you. Just a few things. First of all, the MAS sort of review and the referred last month to concerns the red rating. What, in terms of time frame, do you think it will be before we actually see some improvement on that, Andrew? And the other thing is, it has the estate work on triage started? We've been talking about CQC 2 years. We've been waiting, so I'm hopefully that will have started. And thirdly, you know, more generally, the estate strategy for Oldham, given that the opening of the new building has happened, which has been very successful and is a great building to go and have a look round. And I recommend it if people get the opportunity to do it. But it does mean that there is an opportunity for maternity to expand, and that was within your plans. And I don't know whether or not there's been any movement on that. So I think we just need to pin down some of it.
Do you mind if I take them out of order?
Let's take them anyway.
So the second point in terms of the triage and the estates work, so that has started.
Good.
And that's been, I think it started towards back end of March, and it's in progress. So hopefully that will be ready soon, and that will have a positive impact certainly around some of the BSOS requirements, and enable us to have visual sight of the waiting area. So that will alleviate some of the issues which have been picked up by the CQC. The third point in terms of the overall moves, so we will benefit positively from some of the moves. They still need to be enacted, but we have got some space identified for us to expand into. That will support with some of the antenatal clinic pressures we see as well. Then the first point around ours, what I will do, if it's okay, is take that away, because I know Faith has been working with her team to devise plans to get up to the level and address some of the actions which have come out from that review. So maybe that's something we can bring back in a further paper.
Yeah, and we can talk about it when I come around. So, thank you.
Professor Shaw?
Thank you, Chair. So just to follow on, Andrew, if I may, with the external visit that we had, have the recommendations been provided? Have you received them?
No, not been received yet. I'm not sure exactly when we will get them. I've certainly not had sight of them yet. I mean, just as an overview, I mean, it was a positive day and experience. We had a fantastic turnout by both midwifery and medical colleagues. I think it was well received. There will be elements picked up, and it's probably more around the triage area, which has been picked up in the report. But we are already on with some of those actions, as we've just highlighted around the estates work.
Okay, so maybe there's an opportunity there, isn't there, to align all of the recommendations into one package, because they all relate to the wider maternity narrative, doesn't it? So I'd be really mindful of the complexities that sometimes you can focus on, but I really want to see more alignment in those recommendations so that we avoid duplication and focus on the right things. So looking forward to seeing the recommendations and implementation plan that are going to be set against them, and hearing some positive news hopefully as well.
The last, sorry, I wanted to make Adam's the last comment. Is it in relation to?
Sorry, if I can ask as the CNO and the safety champion for maternity, if I can have something to say about the paper, much appreciated. But understand if Mr. Adams is still on.
That is Mrs. Adams, then Professor Caudle, and then we really must move on.
Thanks. I just think we need to be mindful that in the minutes of the last meeting, I think I'd asked about prompt training for consultant staff. And we have reported verbally that that was then at 90%. I think that's documented in the board minutes. But this paper says that it's at 78%. So I question is it at 78% or is it at 90%? And then if not, we just need to think about amendments to minutes if it's where it needs to be. And I've got a second question, but the second question really is about the training compliance requirements. So 2 to 5 days is quite high in terms of then not deteriorating that training compliance, but actually maintaining the safe staffing on the unit. And so I think what the paper describes is the problem, but not the solution to it. And it's probably not for now, Andrew, but I think in the next report to QPC, we need to almost think, well, what does that translate to in terms of full-time equivalent impact if we are going to maintain those training numbers? And how does that translate through to the people plan? What might be in birth rate fuss? How are we genuinely going to accommodate that additional demand on people, which will require time away from labour ward and financial care? So that's probably not for now, but needs to be addressed with next QPC. I'm interested in the prompt training.
And there is some work ongoing around the workforce, just flagging some of those issues and the demands on time. Obviously, there's certainly a resource impact. And in response to your first point around the training, so the training compliance figures in the paper here for all obstetricians, so that includes specialty doctors, FY1s, 2s, GPSTs. So the figure quoted in here is 85 for fetal monitoring. Consultants are actually at 91.6%. So maybe that's something that should make it clearer in here in terms of the.
Yeah, no, that's right. Thank you.
Just Gordon.
Very briefly, in answer to the questions to when the MAS will be reassessed in 2 months' time. Thank you.
Thank you. Thank you for your comments. And for me, 2 things come out of this discussion. And that's about ensuring there are timelines, because without those timelines, it's very difficult to be able to assess the progress and maybe identification of what barriers are. And secondly, the point about rather than just making a statement, to consider what solutions might be, particularly in relation to the increase in the demand for training, the impact of that upon how the work is actually going to get done. If there are no other comments, can we continue then with the nursing establishment review? And again, can we take the paper as read?
Thank you, Chair. Any questions?
It's very dense. Well, one thing that struck me was variation in who and who is not involved in a particular tool review. There's an identification of certain
yes
disciplines which don't have which are not part of this.
So it's a nursing establishment tool,
yeah,
and the guidance is to apply to inpatient settings that are not subject to specialist professional guidelines around staffing ratios, and that will exempt emergency departments and critical care. And community settings have their own methodology that's currently being ratified nationally, and we are one of the pilot sites to use that. So it is evidence-based. It's about it's quite 8 years old, I think. And yeah, no, so it's quite prescriptive, strict methodology, training, and quite a lot goes into ensuring that there's inter-rater reliability for the people who are assessing the areas. And then it goes through a professional judgment review. So it's quite a robust process, but you're right, there are some areas that are exempt from it.
Thank you. Mr. Parr? Mr. Carter?
Thanks, Chair. Yeah, I've just got a couple of questions on this. So, having looked at the sort of summary assessment, I suppose there's some real good insights in this paper, and I thought it was good to see the detail on some of this. So, we do make reference to a surplus of over 20 hold times on face value that will redistribute or rebalance in higher acuity areas. But obviously, my first question is around that's influenced by the calibration of risk. So as we do this, it's in the context of a certain risk appetite as to whether we need extra staffing in certain areas that we don't. So my first question was just about how satisfied are we that we've calibrated the risk right to get to this conclusion. And the second question, just leading on from that, is more specifically about the enhanced patient observations. So we talk about the level of staffing articulated in hold times for EPOs across. And that's really insightful as well, because if you look at that, as we've discussed, Heather, you know, that's up to anything up to 120 hold times that we're attributing to enhanced patient observations. Some key drivers in there, but I note that the Safer Nursing Care tool is calibrated or takes into consideration enhanced patient observations. So I just want some clarity on, we're not going to be baking that in up front, because that's over £3 million on enhanced patient observations. So we just need to look at how we don't bake that onto establishments, and we review that through the programme of work that you've been doing in the grip control. So just those two questions of risk appetite and the enhanced patient observations approach, and how we take that in and not bake it in to establishments up front.
Yes, thanks, Greg. No, absolutely, because the figure in terms of our establishment needs in relation to looking after or providing enhanced patient observations, it's not predicated on best practice. So it's quite a weighty figure. We need it to keep people safe now based on our current working practices, but to use your language, bake it in might be superfluous as we improve our approach to enhanced patient observation. And that is a focus of the work of our grip and control meetings that are happening fortnightly at the moment. Might have to go weekly now, because we have we are going to focus a lot on enhanced patient observations and other opportunities for improvement. So yes, it's answer your question. We're not baking that in. In terms of the surplus, it is unfortunate that that's part of the summary, but it is to be transparent and upfront that the methodology does reveal that if acuity has increased or dependency has increased, that what's the commensurate increase in staffing. Similarly, if acuity and dependency has eased in some areas, where staffing is superfluous to the need. And we must remember that this is the first time the organisation has used such a robust methodology, and so we are exposing perhaps previous approaches that weren't as well able to articulate the need. So I'm confident, based on the methodology of the Safer Nursing Care tool and the professional judgment applied by directors of nursing, that this is the establishment that we need. And just to say as well that it is the case perhaps that we can ask the question, can we bank the surplus and say, well, that's a potential saving. Craig mentioned risk appetite. It is about what's needed to keep people safe. And as an organisation, we have said that patient safety is paramount. And in addition to the patient safety risk, I think if we deliver care and treatment in inpatient settings where staffing is below what's required, it will have an impact on retention. We will not be an attractive employer, and we will have regulatory scrutiny and action if we were to do that. So there's a lot to be satisfied by having an accurate and robust methodology that gives us the establishment that we need.
Thank you. Ms Clark, then Mr Crowley, then Mrs Lorimer, and then Mrs Allen. And then we'll move on after that.
Please. Two things for me. One, it's encouraging to see that we're starting to make progress on embedding the nurse associates into establishments, and I guess it'd just be helpful to understand when we'll have that work completed, because we've got quite a lot of them. The second is, I guess, and it's partly a request, I suppose, it would be potentially helpful to see benchmarking information as well. So I know in the model health system, the care hours per patient day, whereas historically we've looked quite rich. When I looked more recently, we've come much more in line with our peers. So it just might be helpful in the future ones to just incorporate a bit of benchmarking information to show that.
Thank you. Mr Crowley?
Yeah, it's just a bit of a feedback from the shadow board, which is kind of interesting, because I think when we looked at this at QPC, which we gave it's a good challenge and analysis. What came from the shadow board though was, I suppose, me saying there seem to be quite a lot of exclusions. There's professional kind of view, that judgment that can override. But the view around the shadow board, because these were people involved in it, really does support the rigour. You know, they felt this was a real tool that gave a multidisciplinary approach. The collection of data was, you know, very rigorous and over sort of 3 stages. And it was really forming the basis for budget discussions about our wards staff safely, giving the kind of budgetary rigour to that. So it's kind of supporting that for people who are kind of leading more operationally, that it's been felt to be a real strong piece of work.
Thank you, Tim. Thank you. I will feed that back to the team.
Mrs Lorimer, and then Mrs Allen.
In my whole career in the NHS, I've never met a nurse manager that said they had excess staff. So just on that basis, I would be grateful if we could have some more assurance about these 25 posts in terms of the basis of the professional judgments, because if we're talking about taking some really tough decisions about cutting staff and doing unpalatable things, and then we kind of just take it on the chin that 25 surplus staff, well, you know, not necessarily surplus, but what the kind of scientific approach comes up with is okay because the directors of nursing said it was. It doesn't feel like we're doing the right level of assurance on that. So would it be possible to bring back some more detailed assurance on why the professional judgment is the way it is?
Yes. So the summary is unfortunate because the surplus staff that's been alluded to, and the professional judgment that was then applied, resulted in not necessarily those colleagues remaining with the surplus, but areas where there was deemed to be a deficit or a need. Those colleagues, that staff was used to they will be used, if you like, to fund or to balance areas where there is that need. And in terms of assurance around professional judgment, I think the assurance is the methodology, the assurance is the outcome, the levels of harm that we have, and the years of experience of our directors of nursing saying that this is what they require. The challenge, the process of challenging that feedback as well. And every month there is a safer staffing paper. And I think respectfully that might provide the assurance that this biannual review gives of what it is that we need across the board. But the monthly paper that comes, the staffing paper that comes every month, gives a view of what our fill rate is and our care hours per patient day. And the assurance that you should receive as a board is that care hours per patient day across the organisation is within national limits.
So maybe I misunderstood the paper then. So the 25 surplus is not really a surplus?
No, it's an aggregate number of all the places where the acuity and dependency meant that the establishment at the time was more than was needed. So it's an aggregate view across the organisation. So those 25 plus full-time equivalent nurses that came up as a surplus, what the summary didn't reveal was areas where there was a deficit, and what will be used and how they'll be used to address skill mix changes, ratios, etc. That the professional judgment meant that this is how it will be distributed and reused.
Okay. So my impression was the 25 was a net figure, and that had already been taken into account when coming up with the 25. So that's not the case then. The deficits were not taken into account when coming up with the 25 surplus.
Not after the professional judgment estimate. Not after the professional judgment was applied.
Okay.
Sorry. Okay. So there's a computer says yes or no with regards to acuity and dependency. Across the wards, then that 25% figure is given. The other layer is the professional judgment on top of that, again, which revealed where nurses were needed and where they could be given up. And that surplus figure is used, that net figure is used to plug the gaps where senior nurses have said, okay, computer says no, but we know for a fact that enhanced patient observations, for example, they will need this level of nursing, they will need this level of input. And that's why it will be a neutral figure. We will not be submitting those 25. It will be risky to get rid of those excess nurses based on the
We didn't document that professional judgment.
Yes.
That is documented.
Yes. Sorry, could I just suggest that this is taken offline?
Because I probably don't understand the paper before we get away the chat. Yeah.
After Mrs. Allen has spoken, I'd like to bring this together. Mrs. Allen.
Thank you. So one comment, if I may, and one question. So the comment is, I want to come back to something Heather said right at the start. This is the first time, I think, as a board that we've seen quite a comprehensive overview of how our nursing staff is allied to wards. And I don't think we should misunderstand the scale of probably the work and effort to get to that point. And I think that's really important that this is giving us something to ask questions about. My question is, this will be based on practice at the moment, and we know we carry heavy inefficiencies in terms of people, process, paper, everywhere. For me, I'm assuming that we can use this model as we think about efficiency gains in terms of as we digitise to drive CIP improvement discussions, changes, and use this to also think about how we might model for what the future would look like. And I'm thinking whereby we might change nursing from pieces of paper to the opportunity to use a handheld device. So this feels like a really important baseline to understand where we think we are today. And also I recognise that models will always tell us what good models and science need, but there's always going to be that personal overlay that says, well, what does that reality mean in our world, with our system, our service, our format, our structures? But I found this really helpful, and it feels like this will help us in the future as well.
Yes, it absolutely will. One cautionary response to that is a while back it was felt that digital reading of blood pressure was the way to go to release time to care and release staffing. It actually resulted in more harm, because what happened was nurses became de-skilled, patients hardly ever felt nurses, so they reintroduced physical touch when taking vital signs. So I think it's absolutely fantastic way of using this methodology to help predicate business cases for EPR, but it will not necessarily mean that we can replace nursing care with that.
Thank you. Could we accept the recommendations of this paper here, and in particular the one which refers to the SMCT tool? I mean, accept that. I mean, in doing that, could I just say that I think that this again is another instance where this approach allows the coming together of finances, professional activity, professional judgment, and people. So I think it's a really interesting further illustration of that. And in a sense, it's a different way of looking at the very important forward-looking view that Mrs. Allen has suggested. But I think these two matters taken together really offer an interesting way forward, which should have a benefit for patient care and our colleagues' satisfaction, work satisfaction. So can we continue then, or come back to the discharge integration from one? And I think we have some guests, don't we?
Thanks, Nikki. I'll just wait till colleagues. Okay. I think probably a couple of things to say before colleagues join us. Lindsay Darley, who has been programme director of this programme, shared some statistics with me last week. So the video.
Sorry to interrupt. Do you think it might be sensible if we did another agenda item?
We move to people and education.
What, sorry?
We could move to people and education if you wanted to.
Oh, okay. They're not here yet. No. Oh, okay.
Oh,
are we ahead?
Well, yeah.
Oh,
I'm ready to go.
I'm so pleased to hear you guys.
Sorry, I'm really ready to people committed. Yep. Okay. So take the paper as read, but just reiterate the alert, which was an update on fixed-term contractors provided to the committee. And in total, 106 fixed-term workers continue to be employed beyond the agreed end date of their fixed contract, which was, a bit of a concern to us. I mean, just employment-wise, pay-wise, legally, they've not got a contract, they continue to work. So we felt we didn't have assurance on this, and we really thought, this really needs sorting out. We cannot have people working for an organisation who are not contracted. I've never worked in an organisation where people continue to work when their contract ends because of all sorts of legal, medical, every issue. And we asked them to please try and sort that as soon as possible. And we wanted to, and just one thing about the advice, but the committee received an update on the late stage career conversations project following which for senior doctors, which we thought was absolutely, sorry, my watch is not always wanting to talk to me, which we thought was a brilliant project, and given the value of this work, the committee recommended this work continues, but is embedded as part of business as usual, actually, and that should happen in other, to midwives, nurses as well, those late career conversations. And finally, back risk. Following discussion, the committee is recommending that the likelihood score colleague experience risk on the BAF should be reduced from 4 to 3. We've been discussing this for several months, looking at the data, the charts for people have all been, showed a downward trend and below target. what swung it this time, and we'll go to that next, is the staff survey. Looking at those staff survey results, we felt actually that's the point where we can say colleague experience, we could reduce that risk. And so as a committee, after discussion, we recommended to the board that that risk reduce to an overall score of 12.
Thank you. We'll suspend that focus on people in education activities and go back again to discharge from money.
Come forward a bit. So for newer colleagues that are around the board table, over the 12 months, Adrian and David came to talk to the board about how we might better integrate our efforts in health and care, and in particular think about how we apply a strengths-based approach to the work that we do in the hospital setting in order to move people on in their journey and get them back into their own homes. And I think in that session, Adrian challenged us around the board table, not making any reference to our collective ages, but asking us a question about how many of us wanted to end our days in a care home. And was that, you know, our ambition? And if that wasn't right for us, then it wasn't right for our populations too. So the team have come this morning to talk about the work that they have been doing, that we've been doing across our local authorities with health and social care and with each of our locality partners. This is probably a double act between myself and Heather. Heather has been really sponsoring this from a nursing perspective across our care organisations in terms of the quality improvement collaborative. But this work has significant implications for our financial position in the organisation and also our urgent and emergency care improvement plans. For the team, we watched the video at the start of the board meeting, and Lindsay wanted me just to reflect that if you look at the Office of National Statistics, dementia and Alzheimer's is now the biggest cause of death, leading cause of death in the UK. It's bigger than ischemic heart disease, it's bigger than respiratory disease or stroke, and that's kind of quite frightening in some ways, and leads us to think about actually where do we focus our energies in care and the types of patients that will be presenting in our hospitals and in our communities needing support. The gentleman that we saw was chief executive of his own company, and he had, prior to the team's intervention, had attended the hospital 6 times in the past year and been admitted and was having CT scans, and that was requiring him to be sedated, and he was becoming increasingly distressed with that. And since the team's intervention, he has not been admitted to the hospital system once. So there are some absolutely patient, family, staff experience as well as financial benefits to putting our efforts into these programmes. So I'm going to hand over to the team, and I have the benefit of chatting with some of our exercise facilitators last week, but they're going to talk through some of the work that they've done. We've got some slides in front of you, and we'll take those as read. We're going to try and bring to life what this means for us and why, in terms of the recommendation, we need to continue to support this work as part of the sustainability, I would suggest, of our organisation.
Thank you. David Thorpe, Director of Nursing at Salford Care Org, and I have been Director of Nursing at Bury Care Org. A lot of my experiences through the Days Kept Away from Home will be regarding the Bury site. So thank you very much indeed for that. And I was looking at some statistics over the weekend, because I saw it in a national paper from the Royal College of Emergency Medicine that the higher mortality for patients being in ED longer, which you're well aware, and 1 in every 72 patients will die in ED if they're 8 hours or over, which you'll be familiar with those particular figures. When I heard those figures, I was quite shocked, and I wanted to do something to manage that. And this opportunity came along from being in the NCA, being in the front runner programme. We also found out that dementia and frailty wait longer in ED than other specialties. So our stroke patients and cardiac patients go straight through, where our elderly, frail, most vulnerable are there longer. So these were the figures and data that really got me that excited and passionate to change, as we all have. Clearly it was wrong, and we wanted to look at that. And we were also looking at how many patients were moved. So every ward moved add 2.84 days to that patient, which keeps them away from their home. So there was 2 wards that I will tell you about this morning. Is Ward 8, which is an acute medical ward in Ferry. And we changed that to have 12 patients who had dementia and 8 patients who had medical patients. But also we closed 6 beds to have that area as an exercise, social gathering, etc. And to see how that worked. Ward 8 it was an escalation area, but 24 beds. But we generally use that for our patients who are medically fit, and we were working through that as well. And I'll tell you a little bit more about that. What we tried to look at in Ward 8 is to have direct admissions from ED. So instead of having 3 or 4 moves, we were going to directly admit to that. And we found that a third of our patients were admitted onto the ward directly, which helped. We also found was sedation dramatically reduced from 12.6 times being used to 1.3. So our sedation came right down with these activities, through social interaction, through a more focused approach with our patients. That had massive impact on our staff, both our allied health professionals, our nursing staff, and our medical staff. And in particular, our nursing staff and our physios explained that it's getting back to what I came into the NHS. How they were caring, and it was more enjoyable interacting with our patients all the time. One of the consequences, and I talked to Jason, one of our consultants in that area, and how our medical staff have been engaged and were really passionate about this venture. They said that the patients were now in the same place instead of dotted around the organisation that they were trying to find. They felt that the patients now, because of the interactions from the teams, that the patients were more engaging. They could do a better assessment and plan their care going forward. And one of the big consequences of that, which I hadn't envisaged, was our FY training doctors had a more focused approach because they're on one ward. They were looking at what dementia means instead of patients, instead of being dotted around the hospital, having time to then go to the area. It was a more controlled and time efficient area to assess. From Ward 8, we found that we reduced patients being in there by 6.9 days. And that was just in a very small time. So really exciting. And I'm sure there's quite a lot of contributing factors. But our mortality for over 65s in Fairfield General Hospital was 61. It went to 57 and now it's 53. There's some consequences happening. Sometimes you can't always put your finger on it, but there's a lot of things, contributing factors. Just a snippet of Ward 24, which I mentioned, that incorporated all the 3 elements that we have come accustomed to, which is strength-based, deconditioning, and pathway design. And that was the only ward that took all 3 together and driving that forward. And we found that 30% of our patients were downgraded, discharged. And I'm sure we'll talk about that in the future. I'd like to hand over to Dan.
Okay. Hi everyone, my name's Dan Robertson. I work in the QI team across the NCA, and I'm going to talk a little bit about DCAF, but as well as the progress of the project, also just give a few sort of learning points, because I think because we're part of Discharge Front Runner, one of the things we're being asked to do is share learning across sort of with NHS England as they come. So I think it's probably important to bring a few points out of that as well for sharing today. So David talked a little bit about sort of the dementia and the Days Kept Away from Home collaborative. I think the title of the collaborative itself is probably a learning point, because I think we've learned throughout this around the language around sort of that we use sort of in the hospital quite often. And the Days Kept Away from Home is now starting to replace our terminology around no criteria to reside. So when someone's medically fit, a lot of the time in the past and across the NHS, we'd use the term no criteria to reside, which feels a bit like the blame's put onto the patient for being in hospital. And that's starting to sort of move away towards actually when you're medically fit, we're now keeping you away from your home. And I think that's probably one of the first key learning points. And so the collaborative itself took in 18 wards from across Salford, Bury and Oldham, so 6 wards from each area, and have been working on sort of getting people home. So again, another key learning point is the importance of getting people home. We know sort of in sort of the space where we've worked on before around flow and discharge that we'd concentrate on things like length of stay, flow. But the clinicians that we've worked with sort of feedbacks was that that's not why anyone got into being a clinician, was to reduce length of stay. It was to help people, it was to have an impact, it was to sort of support patients. So actually turning the focus of this way was to get people home. And by getting people home and back into their home, reducing demand on social care, and therefore reducing the delays whilst patients may be waiting for social care packages or waiting for an intermediate care bed. So that's been the real drive behind the work. And again, one of the key learning points. And when we talk to our patients, if we look behind the beds and look at what matters most to me, very often the words will be there: get home, get me home. So that's been sort of a key point, because it's important to patients, and then it becomes important to our staff and our colleagues about making sure that people get home. So measuring people and not process, so moving away from measures that are measuring the process around length of stay and moving towards things that focus on patients and focus on individuals. It's one of the key bits of learning that we're sharing with NHS England. The how we got there, so David touched on a little bit in terms of the World 24 story. We focused on deconditioning, which is getting people out of bed. We've learned that during COVID, I think, well, through fear of infection, people have been more sort of towards getting back in bed and not getting out and getting exercise. So we focused on reducing deconditioning, taking a strength-based approach. So colleagues sort of in social care have a much better sort of strength-based approach. So focusing on that and trying to get sort of focus on the strengths of the individual and the community around them to get people back home, but also the discharge pathway. So David's spoken about that. So apologies if everyone knows this, but when we're making decisions around patients' discharge, we either put them on a pathway 0, which is going home, a pathway 1, which is someone going home but may need a package of care, a pathway 2, someone needs intermediate care, or a pathway 3, where someone needs long-term residential care. So actually, one of the focuses of the project has been challenging those decisions and trying to get the patient home. So trying to reduce the patients who need intermediate care or long-term care, and actually pushing that and actually downgrading the pathways should reduce our length of stay and should reduce the amount of time that people are waiting and should reduce the demand on social care. So that's been one of the key drivers behind that. Give you a bit of the data. So for our over 65s on the collaborative wards, we've increased the number of patients going home from 88% to 89%, and we've reduced the length of stay by half a day. And just to give a bit of context for that, through those wards, since we've seen those reductions up until learning session 4, 7,000 patients have been through those wards. So that the impact of those changes and the work that the wards have done has resulted in length of stay reductions for that group. So what next? So with the collaborative came to an end in November. We've got a change package that we've developed now, which is I think due to go live on April the 15th.
April 15th to Salford in its totality.
So we're rolling out sort of quite an in-depth rollout plan with Salford to then be replicated at Oldham, Bury and Rochdale. And it's quite in-depth each month. We're going to have a focus of a particular element of the change package. And we're going to try and build a system to embed those changes and give us an oversight to see if there anything well embedded or anything anywhere needs a particular focus. So that's it from me. I don't want to.
Thank you. So my name's Hannah. I'm the Exercise and Independence Facilities team lead. I'm an MSK physio by background with a really keen interest in rehab. I've got 4 other members who are all from sport and exercise backgrounds. So the idea is to utilise their expert knowledge and skills in exercise prescription and programming in order to rehabilitate patients in an acute hospital setting, which hasn't been done in the NHS before. And as Danny touched on, one of the drivers for the Days Kept Away from Home collaborative was deconditioning. It's a massive issue in hospitals, and it's getting worse due to the increased wait times for intermediate care and social care. So our aim was to prevent the effects of deconditioning due to strength training using individualised resistance training programmes for patients. So we chose a series of outcome measures, which were hand grip strength, handheld dynamometry, the 30-second sit to stand, and the Mawson's Mobility Index, which is a transfer mobility and balance assessment. We also looked at changes in pathways. So we recorded all of these outcomes on initial and then on discharge, and in between times completed daily exercise sessions with every patient, depending on what that patient needed. And we also incorporated education into that. So educating patients on the risks of staying in bed and the benefits of exercise, providing them with an information leaflet. And we also tried to involve families where appropriate. And I think there's a real opportunity here as well to involve ward staff and volunteers to implement the exercise programmes that we prescribed each patient, and that's something that I want to push moving forwards. We've had 2 phases. So phase 1, we chose selected wards from the Days Kept Away from Home programme, regardless of their pathway. We discharged 154 patients. Of those patients, we managed to reduce the pathway of 24 of those, so that's 16%. That's estimated at over £135,000 annual saving to the health and social care system. But we looked at the way that was working and found that the patients that were waiting for IMC seemed to benefit most. And we think that's because once they've got that plan, they then become a lower priority for therapy teams, so they don't get as much therapy from the physio and OT teams. And they're also often waiting a long time, especially if they're out of area patients. So in phase 2, we all came to Salford and focused on patients that were pathway 2D, so waiting for IMC. That only started at the start of February. We've discharged 31 patients, and of those 14 we've managed to get home instead of to intermediate care. And at the moment, the length of stay, average length of stay for intermediate care is 14 days. So we've got 50% of our patients potentially home on average 14 days sooner than they would have been home before. They've got 14 more days with their family and their loved ones. And not only that, but the new target demographic of just the pathway 2Ds has increased by the percentage of people that we've managed to get home is increased by 3 times. That's 3 times the savings on the health and social care system. So it seems to have so far a massive impact on patients, which leads me to hand over to Sean, who's going to go through a bit of a patient story.
Good morning. My name's Sean Burnham. I'm part of the exercise team with Hannah. My background is sports and exercise at university. And like Hannah said, I'm just going to share a patient story just to highlight the good work that we've been doing. So this specific patient was admitted to hospital on the 28th of January for a revision of a total hip replacement. She has a history of numerous dislocations, and prior to the hospital admission, she was living at home with her husband and son, no formal package of care, and independent with all the activities of daily living. At baseline, she was mobile with elbow crutches, and we picked her up on the 12th of February after a referral to out of area IMC had been sent. At the time, she was transferring with a standing aid and 2 members of staff. We picked her up and she participated in a total of 10 sessions spanning 2 weeks. And these sessions were focused on reinforcing confidence, strengthening key movements that enable mobility, and most importantly, giving her the belief that she'll be able to cope when going home. We utilised gained experience in the industry and knowledge of strength and conditioning research in geriatric populations to develop a plan that allowed for progressive overload at a pace that wasn't seen as too fast from a patient perspective. The key for us was to strengthen movements that enable mobility and be able to be replicated at home, such as sort of knee extension, hip flexion, things like this. And this was done by utilising different rep ranges, weights, and being able to complete the movements functionally, like a sit-stand test, as Hannah mentioned. To underpin the exercise, that this was done to underpin the idea that the exercises have real functional sort of ability to help the patient at home, as opposed to just sort of being in the gym. And it was obvious to see the results. This patient-specific programme led this patient to be able to return home without the need for IMC in just 2 weeks. So she only did 10 sessions, and we got her almost back to baseline, which was well on her way. We did collect some feedback from this patient at the end of her time with us, and some of the questions we asked her were, "Has the time spent with us benefited you?" To which she replied, "Yes, very much so. Helped me gain strength all over my body." And we asked her, did she think that the team was a good addition to the ward? If so, why? And I think this is very important. She replied, "For me, I think they've been the most beneficial of all of my experiences, as it instilled in me the extra confidence to get up and walk. Without their input, I would have needed to go for more rehabilitation. I'm now able to go straight home." So that just highlights the good work that we've been doing already.
All right, thank you. My name is Adrian. I'm the Director of Social Services for Adults in Bury. And the great thing about that patient story is it's one of hundreds. Can I just share a bit of my work experience? I think I discharged my first patient from hospital and did my first improvement programme at Cherry Tree Hospital in Stockport in 1997. We did quite well. We were able to shut a ward, and then it carried on, and eventually they were able to shut the whole hospital. But I've done them since. MRI, we did Red and Green Days, Bolton, we did Safer Bundles, and then here with the Northern Care Alliance. And this has been the biggest and the best and the most amazing programme in all of that work history that I've had. And I'll give you some of my data in a minute. But the thing that just lifted the ceiling off those roofs when we did those learning events was the feedback from the staff. Oh my, wow. You know, I mean, it takes a lot of confidence. I mean, I'm used to it now, standing in front of hundreds and hundreds of people. But you imagine ward nurses and charge nurses and senior assistants standing up in front of hundreds of people, along with therapy colleagues, and saying, "I remember now why I joined the NHS." And it was just like, God, it just really moved me. It was amazing. The amount of engagement from the wards that took it to heart was just absolutely superb. And don't underestimate the need for, you know, really good nursing leadership, which we had. Thank you both. It was really, and you are, wow, these lot are just amazing. You are so lucky. I've had 10 of those in my local authority. They're just great because they just keep all the staff going. So, social care data. I track two things. I track obviously the number of people that leave hospital needing social care, but we also now track the days. And we can do it by hospital, by local authorities, great big data repository in Greater Manchester, so we know how many days people are staying in hospital. And unfortunately, it's not good. So if you're a P3, you need a care home, and you're from Salford, so likely to be in Salford Royal, that's 17 days to your length of stay. That's not the average, that's the median. So most people, it's 17 days. If you can get them down to a pathway 2, it's 9 days, right? This is data between April and December from last year. It's not dissimilar in Bury, it's 14 days for P3 and 9 days again for P2. So you can see why the pathway downgrades are really, really important, because it just takes loads of days off. And I'm pleased that you use the word wait for social care, because that's really important, because it is a wait now. It's simply a wait because we have none left. And I'll give you a for example. So in the last 18 months, Bury now supports 16% more people than it did 18 months ago. And yet the population rise over 2 years in that cohort of older adults is less than 6%. So 6% population rise, 16% rise in use of services. And you sort of wonder, where's all this demand coming from? And it's not a pandemic tap turning on because nobody had social care during the pandemic, because nothing changed in the pandemic for adult social care, carried on exactly the same. You know, nice, slow, steady increases until the last couple of years. And a hospital normally generates 25% of the activity for social services. And by activity, I mean referrals and assessments. And it used to generate 25% of the demand for care. All right. But over the last 2 years, it now generates as much demand for care as every single community team that I have. Right. So it used to be 25%. It's now matched the community teams. So it's actually doubled. The activity referrals stayed the same at a quarter. Demand for care has doubled. So there's got to be something that's changed in the behaviour of the hospital system. And I think, to be honest, it's a reaction, and it's a natural reaction to the policy of discharge to assess and previous free care. And you can't fault staff for that, because we want to help, the nurses want to help, the therapists want to help, and they think they're helping by asking for social care. But we now know you ask for a care home 17 days after they were medium. You ask for an intermediate care bed, it's 9 days. You ask for a home care package, it's 4 days, right? We've done quite well with home care in Greater Manchester. We've been doing international recruitment. We've put real living wage in, so home care is now getting paid just over £12 an hour. And we have still got home care available, right? When we started this programme, I was buying 600 hours a month of brand new home care for nearly 50p, right? So as every month I'm going out to the market, please can I have another 600 hours, please can I have another 600 hours. By the end of November, in your pack, there's a blue line that goes down like that. It was less than 200 hours, and the number of people needing new home care was less than half, right? What is noticeable is that blue line going down exactly matches the blue line going down if you track the 12-hour breaches in A&E. All right. So with the pandemic and discharge to assess, and the government has taught us that asking for social care helps people get out of hospital faster. It does no longer do that, because we simply don't have any left. I used to have 120 care home beds. In the pandemic, it went up to 300 vacant at any one time. Recently, it's been low as 20. We talk about choice. We talk about choice delaying things. In fact, choice doesn't delay things. It's the fact there is no choice anymore, because there's so little capacity. So the other thing I track, as well as home care, it's the number of new care home placements requested. These are the P3s that can't fit into the discharge to assess beds, can't fit into any of the capacity or intermediate care. I mean, gosh, I wish I had foresight, because I'd have never done discharge to assess with the extra money we got from the government. I'd have bought more intermediate care, but it's a bit late like that. We were doing 5, 6, 7 a week in April, 5, 6, 7 week new placements. In November, I had 1 placement request. You know, even if I look at the averages, you're looking at, you know, a quiet month, 8 or 9 new care home placement requests. In November, it was 1, right? Now, what that did is it meant that instead of just having 10 or 20 care home beds empty across the whole of Bury, and I have 1,800, it crept up to 30, to 40, to 50. And that's great, because at that point, capacity is back in the market, choice is back in the market, and ease of access comes back, because people have got a choice and you can make a choice faster. So a little bit extra capacity in the care home market suddenly means that it doesn't take 17 days to get a P3. It starts to drop, and it starts to drop quite quickly. because people can make a choice faster. Never ever seen a programme drop demand for services to those levels. Over half for home care, 5 times lower for care homes. I mean, this is monumental. And remember, 17 days for a P3, 9 days for a P2, 4 days for a P1. Every single downgrade saves you hundreds and hundreds and hundreds of days, because that's over thousands of patients between April and the end of November. Now, December, it's been creeping back up again. There have been changes in the collaborative. You look at our data, it's not so good anymore. And sadly, exactly the same blue line going up for social care services requests matches exactly the same blue line going up for the 12-hour waits in A&E. I can't tell you how seismic the shift was in timelessness of access to care because fewer people needed it. We just took days and days and days off. And it was great because that wasn't the intention. This lot didn't go across the boards going, you will reduce length of stay and you will reduce the pathways. We just put person-centred care back in. We had strength-based conversations. And most importantly, for people with dementia, we reduced the disorientation. And for people who were frail, we reduced deconditioning. And that's what good care is about. And that's what the programme was about, good care. But the monetary benefits, the capacity benefits were bigger than I've ever seen in all of those programmes that I first did in 1997. Show me age now. I just can't underestimate. I mean, please carry on doing it. I'll give you a little for example on the money. So every single local authority and locality got an urgent care grant before Christmas. And Bury's was £400,000. We're only a small authority, so we don't get as much as many others. And you know, what do we want to spend it on? And of course, the request came back with respect to David and his colleagues. Can you buy us more beds? Please no. I gave in and I bought some nursing beds, right? £250,000. And when I look back on what those nursing beds delivered, it was one patient left hospital 2 days later, every other week, 12 weeks, for £250,000. Right, one patient every other week, 2 days early. Wouldn't it have been amazing if we could have spent £250,000? Because I now get £3.5 million a year from the government for discharge services. I spend £100 million on care every year, right? I have 16% extra people in my system. So I've got £3.5 million, it's great. But all this additional demand in my system is currently costing me £16 million. I don't want to spend £3.5 million a year on discharge services. I want to spend £3.5 million a year on this. And the aim is, if we can do this for a while, the money that we do get from government might be released and we might be able to help this, right? Because we've got to stem the demand for services at the point of discharge, because we're lengthening length of stay. We're meaning that people are prematurely entering the care system. And the worrying thing about people who prematurely enter the care system is people who get care come back into hospital more than those who don't. So actually what we're doing is we're stacking up demand for hospitals over the next 2 years as well. But I just repeat, I've never ever seen anything deliver a level of staff satisfaction and engagement to this, and all the other capacity and monetary benefits, which wasn't primary.
Thank you. Thank you, Beth. We've been given some amazing feedback, and I think actually it's probably whetting colleagues' appetites to learn some more about the success of this. So I know we could spend all afternoon speaking about this, but unfortunately we can't. So what I'm going to suggest is that colleagues think about how they might like to maybe spend some time with parts of the service. I've done it with one part of the service, and it's extremely interesting, and we can feel change in the atmosphere. So can I suggest then that we thank our colleagues very much for their comprehensive feedback and that we move on.
Yeah, before we do move on, can I just make a comment and ask two very quick questions, if that's okay? I'm very happy for those questions not to be answered now. I would like to ask a couple of questions, if you don't mind.
Okay, but briefly.
First of all, I want to thank the team for coming today and picking up a theme Adrian brought in. You've reminded me why I'm here, so thank you. Brilliant, absolutely brilliant. And when Adrian Krupp says it's the best example of improvement that's been involved with, we should obviously we really should. Two questions. First, the money, of course. The slides say that one response we've got is shifting funds around the health and care system to keep this going and expand this at a time of severe financial challenge, which we're all facing. Any suggestions about how we can face that, either through a pooled budget or through longer term planning? We as a board this year have introduced a 3-year financial sustainability plan. I see no reason why, even if it's only on the basis of the ring-fenced level of nutritional care, we shouldn't do that on a multi-agency basis. So my question is, how do we face the financial challenge of this? It is saving us all money, and moving mad not to collect that money and reinvest it, doing more of this, instead of spending money keeping people in hospital when they shouldn't be there, or worse still, putting them into care homes, then that just sends them back towards more people, etc. So the financial issue has got to be addressed, otherwise this one's not. It's the only something. And my second question is about this is about working for non-care alliance. I think Adrian said that this is being rolled out now across very old and not solved with farming, but any concerns about this being rolled out effectively in a mainstream way? And at some point I'd welcome more input from you about other examples of improvement at locality level. For example, before people get anywhere near A&E, through things like rapid response, that source of response. What else could we be doing of this nature that's going to help us as a board face our performance of financial challenges? Because I don't think without this we can do it. Thanks, Joe.
Thank you for those questions. Could I ask colleagues from the team to send some feedback to those questions, and then we can share them with the board? And once again, thank you very much indeed for your amazing work. Thank you.
Hello.
The people want a comfort break. Could we move then to the national staff survey?
We didn't finish. Chair, we didn't finish.
Oh, sorry.
Thank you.
So,
the final point was about the back risk, and the committee recommended to the board that we reduce that risk. And so we were
So you would like us to accept that?
Yes.
Thank you. Can we move on then to the...
Well, do we accept that, Chair? I'm asking the board.
Yeah, sorry, I thought I did ask that. Can we accept that change? Yes, any buffer?
We can, yeah.
Thank you.
Sorry, I just had a small question.
Of course.
You mentioned in a lot that we were expecting some reassurance on the questions you asked. Do we know when that's coming, or we could
No, that's why we said we were not assured. The first part, which was the alert,
Yeah.
which was on the fixed test contrast, we asked them to come back to us next month because
It didn't indicate when
we
we're
were
coming
not,
back.
sorry, yeah, it didn't, sorry, because we were not assured.
So I'll get that.
Yeah.
Right, third time. Can I?
Survey.
Yes, please. The staff survey, the good news.
Yeah, so there's an awful lot of information in the presentation. I'm very conscious I'm not going to go through it all. I guess it would, before we go to questions, I guess, in terms of highlighting the positives, what is incredibly positive is that we've made really good progress on the things where we focused a lot of our attention. So flexible working, health and wellbeing, learning. So we've improved in 80 of the 98 questions, and where we've declined, they're very, very small declines. So I think, and I think we have to recognise the contribution that the leadership programme has made to that. So I think what's really encouraging is we're starting to see the green shoots from the work that we've been doing. I think probably the areas of concern, and certainly that we formulated into our NTA-wide action plan, are probably around negative experiences, whether that's for particular groups of colleagues, whether that's race, misogyny-based behaviour, or experiencing violence. I mean, I find it absolutely unbelievable that we have 74 colleagues who've experienced violence from their managers and 173 who've experienced from other colleagues. I mean, you know, it's just completely unacceptable. So we will be putting together an action plan, particularly around that, to make sure that we're responding to all that feedback from our colleagues. So I think the only other thing to flag was when you look at the results across the care organisations, there are some that aren't doing as well. So, for example, diagnostics and pharmacy, but actually if you look compared to their results the year before, they have made some significant improvements, and that's also really encouraging because and certainly diagnostics and pharmacy, I know, were one of the ones who had the most comprehensive action plan and really gave it strong senior leadership attention. So it's good for them to see some results coming through. So we are pulling together a NCA-wide action plan. The care organisations are pulling together their local action plans, and they will also be focusing their attention on particular hotspots where there are particular poor results. And we had a session 2 weeks ago, Improving Together session, where we shared some of the positive stories from people who'd made real progress this year based on things that they'd done to respond to last year's survey. So happy to take any questions or comments. I think we've made really good progress, and but we're still in the middle of the pack, and I'd love us to be reaching out from that middle and getting into the top quartile. But the green shoots are there.
Absolutely. Thank you. Mrs. Mayor.
Thank you. I mean, it's a good piece of work. It's reflected in trajectory of travel. I think, like you, I'm astounded at the violence between members of staff. I find it absolutely incredible. We've got colleagues who have inflicted some kind of assault on members. And I think that our message in terms of what we heard last month about misogyny and our values, there are people within this organisation who really quite simply don't match up to these values and shouldn't be with us. And we need to encourage people, support people coming forward. And I feel so passionately about this that we're rubbing shoulders alongside people that think it's okay to actually assault a colleague. It's unbelievable. Anyway, I have to stop because we'll go on forever on that. The other thing I remember was a year or so ago saying that the one thing we needed to focus on was Salford, because of our concerns about how Salford was failing. And I see here in the action plan that only that 50% of the action plan progress has not started yet. So I don't get a sense of the trajectory of improvement in Salford that perhaps we're seeing in other places. So the question is, what have we done to support Salford? And is it paying dividends? And it isn't. What more should we be doing? It was something that we challenged ourselves to do, and I don't get the sense that we've done it.
Thank you.
Can I'll just respond to that, and Aziz will maybe come in on it too, because Salford happened to be the care organisation that came to People and Education Committee this month when we went through the results. So that question was asked about the delivery on their action plan. I think there's two things. I think one, they haven't made the progress that they would have wanted to. I think because we set them quite a challenge on the we need a really strong improvement trajectory. I think Lorraine, the HRD there, would probably acknowledge that their plan was probably over ambitious in terms of everything that they could do. So I think it's probably two things. So might they have completed everything if they had a less ambitious plan? Possibly not still. But they did set themselves a pretty ambitious plan, but we have picked it up. And the colleague experience team who try and dedicate their attention, they spent quite a bit of time with DMP last year because they had some of the worst results last year. Is how we now do that to support them with more external help in Salford. So we will pick that up.
Thank you. Dr. Adair, then Mr. Rashid, then Professor Shaw, Mr. Little, and Professor Culloden.
Thank you, Chair. So briefly wanted to come back on something that Chris said. It is clear in our day-to-day interactions with colleagues that there is a hangover of people feeling that when they raise things, they will not be addressed. So I think there's a leadership challenge that I'm, if you like, reminding all of us to keep focusing on, which is when things come to our attention, we will address them and they will see change in the organisation, and hopefully that brings them back to a situation where things are raised a little bit more proactively. The point I wanted to make was I think we've made fantastic progress on the staff survey overall. I think it's important to acknowledge, if you like, in my portfolio, that one of the areas where we haven't made the progress that we want to make is within our medical colleagues specifically. And so we've had a bespoke presentation from Amy and Keeler as to some of the challenges that we're seeing in that space. And we're working in the background to develop a bit of an action plan specifically for medical colleagues that can be taken into account as we move forward to try and be better overall for the organisation in the next cycle.
Thank you.
I think the whole team working across the Northern Carolina should be congratulated, considering the difficulties that the whole NHS has faced in the last year. I mean, every month we are talking about the huge challenges we face. For us to get a staff survey result where the vast majority of questions have shown an improvement is a testament to all the work that's gone on by all managers and leaders and staff here, and I salute you all actually, and think that's an amazing result in a really tough time. Amazing. So well done, everybody. Yes, Chris, I spotted that too on Salford, and so we discussed about there has to be some focus in Salford about what's going on here. One of the caveats of that is they're actually the most improved care org in terms of their performance last year. So, so work is happening in Salford too that is improving the situation. But I do think, and Nikki agrees that some focus needs to go down in terms of what happens in Salford. The only one more point I'd make, and we did discuss this at the meeting, is disability. If you look at that, I mean, it was really interesting for me to see the staff survey. You may remember about 3 boards ago, I pointed out that I read a report where we were second from bottom in terms of how our staff felt. Staff with disabilities felt about how they were treated in Northern Carolina. And I know it's going to be a priority, and I just wanted to highlight that. If that needed reinforcing, look at that staff survey result. It's really, really disappointing, and I think that must be an area of focus for all of us in the next year, because it's, you know, I don't want to work in an organisation where disabled staff feel like that, and I'm sure none of you do either. And there's something we're doing very wrong that we must get right, and let's put some effort into that, because it's not right.
Thank you.
No, I'm holding mine on.
Oh, yes.
Now it's questions.
Just. You want to go?
Very quickly to say that I joined the staff event last week or week before. Notable for two things. One, the volume of staff that joined it. There were hundreds on the call. And secondly, whether they're all self-selecting happy staff, I don't know, but they really were up for it. I was really impressed. Now, it doesn't take away any of the negativity we've got in the detail of this, but it was a really impressive conversation with some very motivated staff, I thought.
I'm back. Okay, I'm not going to touch anything. So my comment really was an observation or a question, and I want to preface it by borrowing the words from a journalist or colleague who wrote an article in the HSJ last week, which is, "I'm not an angry Black woman. I'm just disheartened by the lack of representation in NHS comms." And my question is about comms around slides 31 to I think 43, which talks about negative experiences. The three sort of, what I wasn't able to see was, out of the negative experiences and the characteristics against which they were levied, disability was identifiable, sexual violence in terms of gender and sexuality, but I wasn't clear on whether the discrimination was just about race or about other, or collectively. So the slides 31, and I was just thinking in terms of, you know, just following on from what we're discussing about colleagues who are disabled, what they're experiencing. Are we accessing the right language to say it as it is, regardless of the characteristic and the discrimination, so that people have the psychological safety to talk about their experiences? And I know that our disability colleagues are saying what their experiences are. We've got women in the organisation and people from the LGBTQ plus community talking about their experiences. Are we hearing enough around racism in the organisation? Maybe we are, but in an organisation where in nursing, and I have some moral injury about this, whether our seniority or representation at senior level is very, very poor. When I first came into the organisation, that was the intention. Are we talking about all elements of racism and negative experiences in an uncloaked way? And I came to that observation by the slides, just nowhere in these slides talking about racism. I may have missed it, but racism or anti-racism, racism. It's clear when it's about disability, being discriminatory against someone because of their disability. It's clear about homophobia and sexism. It's less clear about racism. And again, I was end by saying, not an angry Black woman, but there is something about how we communicate and the words that we say, those things.
Ms. Clark?
Yeah, so the focus won't be disappearing, because Owen and I were talking yesterday around the work around the anti-racist framework that we'll be doing. So there are some small elements about discrimination in the slides later on. But no, we absolutely, and also conscious that the Breen report that also raises racism issue. So we've absolutely know we need to focus on that, and it's how we make sure we bring the right focus to those things. We've probably done the most we've done on that. So the Rochdale piece of work around about 5-6 nurses. And then progressing as well as the Lead Positive programme, so around the point around how we support people to progress from a career development perspective, but the focus will not be going away.
Could I comment on that? Could this be an area explored in, you know, the fact that we can have our own question we can add some questions specifically related.
Yeah, no, it could be. Yeah. It could be something we look at. I mean, I think that there's no other questions that my only concluding comment is, I guess I should have said this when I presented the information, but you also have to remember that we ran this survey about 3 minutes after we'd introduced car parking charges and all the changes, and introduced during it we introduced all our grip and control measures. So I think as he referred to the context, but there were two quite specific things going on here that would have impacted colleagues.
Mrs. Drinkwater?
I agree with everything that's been said about focus areas. The area that stood out for me was about just the numbers of people who don't feel that they can raise concerns, and whether that's because they feel there is racism or they're being treated unfairly because of a disability, or they have some patient safety concerns or colleague concerns, safety concerns, they just can't say it. And when I look at the slide that breaks that down by group, I can count on less than one hand the number that have got to 50%, and it's all much, much lower than that in terms of the number of percentage of people who feel they can raise a concern or that it's listened to if they do raise something. So I do think there's something culturally, and even the car parking and the grip and control stuff, if people feel they can't raise a concern, then culturally we've got a real challenge. So I do think we need to focus on that.
No, and that's forming part of the negative experience, if I can describe it like that, in there, because actually how starting point is how do you hear about them?
Yes.
I think one of the reasons, it's not the only reason, is that often when they do, they don't hear anything back. So they do a bit of a, what was the point in that then? And they don't feel listened to, and that then becomes a behaviour that becomes reiterated as you go along. It's not the only reason, but it is one of them.
I'm just going back to response rates, and our target is 50%. I'm just keen to understand the driver behind that, because to me it sounds quite low. And, this is for me a definition of how our colleagues would say whether this is a great place to work, and expect it to be probably 80% or more. What's the driver behind that? And so what's our ambition?
Yeah, so I joined from the private sector, from Boots, where we used to get a response rate of 95% every year in our staff survey. So believe me, it was a bit of a shock to my system when I joined the NHS. 50% is a really good response rate in the NHS. So we're above the national average. Not that I know, not the same as that's low, isn't it? So the 50% was a realistic increase based on what we got last year. And we achieved a significant improvement, which I have to say I'm pleased with, although there's a lot of work done running around encouraging people to respond. I would love to get a much higher response rate. There's something about the staff survey and the DNA in the NHS that it has never had those sorts of response rates that you get in the private sector.
But I think it goes back to what Cameron was saying. We probably need to take some actions in order to give confidence to people that this is important.
Absolutely.
And then they will get the confidence to speak up. So I know we started with 20%, but as actions are taken, then people believe that this can be used. So I think I would encourage us to probably to push our ambition higher through taking action so people can speak.
We did, and we did a lot of in the going out to encourage response rate of talking about what we've done to remind people of the things that we've done. Talking to them about responding to the survey. So we will. I'm sure we will set another stretch target next year, but I doubt it will be 18 next year. Maybe.
Thank you, Dr. Williams.
I think I'd like to just give a little bit of shout out to Amy Goodale and Keela Roberts in the team, who certainly to that 50% claim, without without them walking the floors, and I did a bit of walking with them, we wouldn't be at 49%. So I think it's just something about recognising that when you do get out, that's why I will always keep reinforcing the importance of visibility in leadership. When you do get out, Carmen, the absolute message you get back is, why should I? Because I haven't been listened to in the past. And, you know, almost 1 in 2 people that I would speak to who was reluctant would talk back, in some cases, decades of when they raised an issue and a feeling that there was no action that would and I think that's a real area that we really need to focus on is, you know, when a concern gets raised, what actually happens. And that's why Heather gets sick and tired of me saying it, but I'm never going to stop. When I talk about datix, for example, and I think yesterday I was on the datix system concluding a datix, and, you know, it is just not intuitive. And I'd like to consider myself as reasonably sort of information technology literate. But if that is going to be one of the places where we expect people, first of all, to record what their concerns are, and it's also a mechanism for feedback, it's not satisfactory. And a lot of the NHS uses datix and whatever else. So either we improve what that is, and of course, you know, I'm conscious of live streaming, and if there's any colleagues who are involved in our organisation in administrating datix, they do a great job. But I think they do a great job with something that is not fit for purpose, in my personal opinion. And that's not just me from a distant level, that's me as a person who uses the system. So I think there's something about how easy is it for people, first of all, to raise their issues. And then when we've got that information, do they even get a courtesy that says, are we seeing your issue? You can expect a response by, or if we can't meet that deadline, you get, I'm sorry, we've not met that deadline. That for me is the crux of this, is our ability to really, really demonstrate that if people open their mouths, if they raise issues, that something will actually happen. And, you know, again, I'd say, Heather, in terms of the you know, the race dimension of some of this, you know, I think the Breen report, again, it's really, I think it's quite clear that we need some attention around some of this, and in some of the conversations that Nikki and I have had. One of the things that can happen sometimes, and particularly, you know, let's face it, I'm conscious of PERD, so I've got to be careful about what I say, but we live in an era where not everybody is brought into the concept of diversity, let's put it that way. And so sometimes there can be what I would call potentially a bland approach. So what you kind of have is you have an equality, diversity, inclusion approach, which is all encompassing. And sometimes what happens then is particular things get lost. But I think we've heard enough as a board, and I really go back to Chris's comments earlier, we've heard enough as a board. We've heard about racism, we've heard about misogyny, and we've heard about people with disabilities and long-term conditions. So now it's time for us all to step up and start driving some of this stuff. And Katie's here today. I don't know if it's by coincidence or planned. I collared her a little bit earlier because Katie's actually doing some really good work, particularly around disability. But it's kind of like, it's based on Katie's goodwill, actually, that work's being done. And I think there's something, you know, we want to do, and we want to move on stuff. Katie's been doing a piece of work which pilots, you know, for interviews, giving people the interview questions. Okay. we've had a conversation recently that says seems to be quite good as a piece of work. So why is it not an NCA piece of work? You know, so the time, so we come up with initiatives like the presentation we had earlier about, you know, days away from home. So like, come up with initiatives. We need to increase the speed now for these things to be enacted and become real. And I think on racism, we were in a board meeting several meetings ago where we made a commitment to anti-racism, but we now need to make that real. We heard 3 colleagues here last board meeting really saying some really clear messages that we've got a survey, and as Aziz has pointed out, let's not do 4 or 5 board meetings down the line sort of having a rehearsal conversation. Let's push ourselves, I think, would be the message on that. Thank you, Chair.
Thank you.
I just respond to Owen's points there, and I agree with you. I think the work that Amy and Keela have done has been fantastic. I went on a couple of walkarounds with them to different wards on different days, and their enthusiasm was fantastic. And they were exploring why people felt they didn't have the time or the inclination to complete the survey. And they went armed with data. You know, X% of you guys have filled it in so far. We don't know who you are. So it was all very, very comfortable, and it wasn't pointing out. And I saw a real mixture of some leaders who heard the message back, which was, what's the point? Nothing happens. Who responded really positively to say, well, do you remember when you raised such and such? Well, haven't we done A, B, C? So they were being real leaders. And others who responded to say, well, I just hear, what's the point? Well, you might do, but what do you do about it? And I did ask that question a couple of times, and people just need to be asked the question, I think. But I think that those 2 and the people who work with them, and it's not just 2 individuals, have done a fantastic job. And we need to see more of that. And I just wanted to say I observed that and I thought it was really, really good. Pass that feedback on. Thank you.
That's good.
Sorry, I just wanted to say that in terms of my comment earlier, I think my point was that we are doing quite a lot. And as people have spoken, some of what I was thinking has come to light. The purposefulness about which we go about things gets lost in amongst colleagues. So, for example, the feedback we got from LMS assurance visit was that colleagues didn't realise that they were being visited by the safety champions. But that's because we were, you know, Chris and I go and visit them quite regularly, and we're getting our sashes made. Chris, I don't know if you blue with silver trimmings and pink trimming. And so my observation was, or my reflection was, is it something about us being so active in this space when we have an opportunity to use language and role model that we use it? That was where I was coming from, that we're doing quite a lot. We know that, we are the choir, and there are lots of people out there by seeing these slides can get that message through, and it wasn't there for me, all the things that we're doing.
Thank you. Can I just make one comment before we move on? And it's in relation to the analysis for care organisation, and in particular, maternity comes up a number of times in that analysis for the elderly care organisation. And so I guess it's a plea to see how that data triangulate with what we already know about culture in maternity. That could be pursued. I think that would be very helpful. Thank you. Can we move on then? We had a really uplifting, encouraging conversation. The next agenda is medical appraisal and revalidation.
I'll be taking that chair if that's all right. Dave Ross has sent apologies because he's stuck in clinic. So this is the medical appraisal and revalidation report. A little bit of context briefly, and then I'll just take questions. So this report, the attached appendix, submitted to NHS England Northwest in November. And so we are rectifying the fact that it didn't come to board following that, and then we will correct the cycle so it comes near the end of the year moving forward. It covers medical appraisal, medical revalidation, and responding to concerns and the governance structures that are around that. And things that I will highlight are the fact that there's some really good practice which is highlighted in the paper that's been adopted elsewhere, but also a few areas of challenge that we just need to be aware of as a board. We've seen a significant decrease in the quality and engagement around appraisals. And this is, we think, related to some of the chopping and changing that has come from GMC over the past couple of years. So they paused appraisals for a while through COVID, and then did a watered down version of appraisals for a while. And so that, plus the fact that we have a pressured workforce, has meant that there have been some challenges in that space, which are described in some detail in. The other thing to highlight is we found that there is lack of consistency in terms of the time allocation across the different specialties and different services for people who are appraisers and give them time for appraisal. So we will be rectifying that. And just to put it on everybody's radar that we are on a trajectory where some of our non-medical colleagues will become registered and will require some sort of appraisal arrangement. That'll include our physicians associate colleagues in the future and aesthetic associate colleagues as well. So those are things I wanted to sort of extract. Just to point out, there are 3 reports appended to this report. One of them is ours for the organisation. You'll find there are another 2 reports for 2 hospices for which we provide the responsible officer function through an SLA. So just so you're aware that that is the case. I'll pause there and take any questions.
Absolutely.
Just a question about particularly the where does SAS doctors fit within this process? And are there any things that, as a part of that process, we need to have regard to for that group of colleagues?
Thanks, Ron. So SAS doctors sit under the same umbrella. So medical appraisal and revalidation covers all medical colleagues, regardless of anybody who has a registration and a license to practice. So they sit under the same umbrella. This is collective data that covers them. If you look at figures, what you just have to be aware of is that we refer to approximately 1,400 plus colleagues. That's all of the medical doctors that are employed by us as an organisation of different grades. We have another cohort of 600 to 700 doctors that are our trainees that sit in another bucket and have a different responsible officer. So in short, SAS doctors included in this, and we'll go through the same process exactly.
Apologies, Mr. Brown, I didn't realise you were thought.
Right. Crowley.
Okay, yeah, it was just, although we didn't consider this report the shadow board, there was a related discussion. And it was, I suppose it was triggered by some of the consultants there yesterday. They don't get a my time discussion. It probably triangulates maybe back to the staff survey where medical colleagues are their responses were less positive. So it's kind of maybe one for the People and Development Committee to kind of think about at some point in the future. So the absence of that type of discussion, and it's not usually your line manager would conduct this medical validation. So there's not a kind of it doesn't have that quality of discussion for that purpose. And conversely, that although we talked on it a little bit, who's coming under this model. Allied health professionals, for example, there's not the same fitness to practice discussion for them. So it's kind of an interesting one. We've got one cohort missing the my time quality and another cohort where we are not getting assurance on fitness to practice. So it's kind of an interesting piece that I hadn't really reflected on in that way. So it may be one for us to think about, not here today, but elsewhere.
Thank you. Brief comment on that. So they are slightly different. It isn't generally done by your line manager. In fact, from a medical appraisal perspective, in some ways you wouldn't necessarily want your sort of clinical line manager to be the one doing it. There's an active discussion that we're having within, if you like, the medical leadership about how we reconcile that, because there are colleagues, certainly from a medical leadership perspective, that we absolutely want to have my time discussions. But lots of the elements that exist in my time obviously will be part of the medical appraisal. It's the lack of a link to your line manager is part of it. And the other bit is sometimes with the objectives, they aren't quite as laser focused as the my time discussion in terms of sort of direct work related things, partly because it isn't your line manager.
Yeah. Before we continue, could I just ask that reappearance yet again of variation? And I just wonder what impact that might have on colleagues' experience of working at NCA, especially in light of the focus last ward on the experience of female medics. And again, links in with the that survey. I'm just posing that question.
Yeah, absolutely. I think that's important. I think there's always going to be a bit of variation because the medical appraisal cycle and revalidation, that's a statutory requirement for our medical registered practitioners. So unfortunately, we always have to have slightly different processes. We are trying to reconcile my time and appraisal to make sure that that's the case. Related to the experience that our female colleagues, and especially sexual harassment, that's something that we are much more conscious of now, and is more and more part of the discussions that we would expect to be brought up within the appraisal discussion.
Thank you. We're being asked then to Professor Shaw.
Thank you, Chair. So I know from the report that we are broadly compliant with NHS Northern North West requirements for revalidation. However, there are some areas I feel like just like some further information if possible. So I note the quality and value of appraisals has been pointed out that we've seen a significant fall in engagement and the quality of the appraisals noted. I'm really interested to know why that's happening, what's contributing to the decline. Is it because of service pressures, staff burnout, and how will we address the effectiveness of any intervention being put in place to address that? Because revalidation is so important for the professionalism of our medical doctors, and we as a public want to make sure that they are not only revalidated, that gives us assurance that they are safe to practice. So there are underlying things here which is really significant, and as a board we need to monitor. The other point around revalidation, recommendation, deferrals, again, you know, what is it that why is there a delay in completion of anti-source feedback? And you're reliant on other colleagues to provide that information, but what's getting in the way of that not happening in a timely manner? Because that has its own impact on the person who's trying to have their revalidation date confirmed, but they're waiting for further information which they have to submit as part of that process. And then the management of concerns about doctors' practice. Given the ongoing review and change to ensure timely, fair and robust responses to concerns about doctors' practice, what specific changes are being implemented to improve this process? And what are the plans for monitoring the impact of these changes, protecting patients, doctors and the organisation's reputation? Because that kind of is a correlation for me of all of the points I've just made, and really contextualises very fundamentally. Our focus has to come back here to understand, you know, what more can we do and what can we as a board see to evidence that improvements are being made, because helpful to our medical doctors who seek the revalidation is also helpful for the mirror view on ensuring that we have competent doctors who are not being the right move here, not be compromised because of themselves, but because of their dependency on others to complete forms and the process. And I have one other question which I would like to ask, please.
Did you want to respond to those, and then, or do you want to add the question?
But this is relating to the registration of physician associates.
Yes.
And our associate in anaesthetists. I think we as a board need to understand the implications of that and the impact of that, because they will be registered under the GMC. They will be called medical professionals. We need to make sure that patients who see them understand they are not medically trained doctors, but they are medical professionals. And we need to appreciate the big gap of understanding of the public about how these individuals practice within their safer realms of care, which they are trained and competent to do, and where they are not trained and competent to deliver that service. And that's a very big challenge, I think, for us to understand, but we need to unpack it as a board and appreciate its impact upon us to ensure, again, that we're providing safer care in the right place at the right time with the right set of competencies and skills. Sorry, that's okay.
No, sorry, thank you. Let me try and tackle those. So engagement and quality of appraisals bit, we think is multifaceted. As I mentioned, we think some of that is the loss of some of the rhythm around the cycle over the past 3 or 4 years, essentially because of the changes from the GMC side. There is also the reality of us being under massive pressure, and we talk to colleagues all the time and we see how pressured they are, and so that contributes to it as well. I am quite assured that we have a robust process for the appraisal and revalidation side. We recently updated the policy. It's a good policy. We have a good team and good follow-up, and that's part of the reason why we are very aware of any variations in the quality, because there is appropriate scrutiny, and we can pick that up pretty early on. The deferrals bit is something that probably is worth just a bit further clarification. In the numbers, if you look at the paper, the ones that are labelled as deferrals, those are ones where something's happened. We aren't going to put in a recommendation for revalidation, but it is in agreement with the responsible officer, and the responsible officer feels that there is a reasonable reason for us to make that deferral. And once that happens, what's wrapped around that colleague is additional support, essentially to ensure that they are heading in the right direction and that they meet whatever timelines we've agreed around that. So, and sometimes there are really good reasons like maternity leave or things, or long-term sickness, etc. So less worried about the deferrals. The one that would worry you there's a 6 in there, which are people who haven't engaged appropriately, haven't quite gotten there. But if you think about 6 in the context of the size of our organisation, that's a relatively small number of people. The responding to concerns bit, I think we still have a bit of work to do. I think there's been a lot that has happened over the past 12 to 18 months to improve that process. Certainly the number of people that are under some sort of process has significantly decreased, and for the most part we have robust plans. I think on a few things we could be a bit more timely in the way we address things. I mean, Carmen and Nikki can probably comment on these things as well if they wish. But I think there is something about improving timeliness and ensuring further consistency across all of our organisations. Final point, I think, was the PAs and AAs. I think it's important to highlight they aren't going to be referred to as medical professionals. They're going to be referred to as medical associate roles, essentially. They will be regulated, it is likely, but they're going to be regulated by the GMC. The details of what that looks like is still unclear. There's a lot of noise in the media and in the medical community and in the healthcare community at large about the roles and about some of the challenges, risks, etc. As Owen and I have had this conversation before, physician associate roles, anaesthetic associate roles are not new. We came to them a little bit late in the UK, but they're very, very well established in terms of the role that they play in other health systems, and they can have a very constructive role to play. There's more for us to do in terms of ensuring that we wrap around them the right support, supervision, etc., so that they're integrated in the right way. And that's a piece of work that's ongoing now to ensure that we have an NCA policy that clarifies that for everyone, so they are supported and colleagues who work with them and supervise them are supported as well.
Thank you. Could I suggest that we come back to what we've been asked to do in relation to this item? Can we we've reviewed the information which has been provided, and it notes there what exactly we've been presented with. And secondly, we can confirm that we considered the report which was submitted to the region. Thank you. Could we continue then with the integrated performance report? Mrs. Adams.
Thank you. This is pretty much our penultimate report, end of year scorecard for us as a board, really. There are, I guess, some updated performance figures that I'll just share with colleagues. So if we go back to our plan that we submitted at the start of the year, we had predicted that we would have 0 78-week waiters. That was on the back of a year of no industrial action. We know we've lost over 40 days of industrial action throughout the course of this year. We had predicted in the resubmitted plan that we would have 1,800 patients, no more than 1,800 patients that had waited over 65 weeks, and I can't quite remember the number for 52-week waiters. On all of those, the teams have done a phenomenal job. They are still validating the final position before we submit it today, but we will have 23 patients waiting beyond 78 weeks. I would say there are none of those in dermatology, so we know an enormous challenge for dermatology in terms of cancer performance and the impact of that on long waiters. So the team have done a fantastic job. The bulk of those, probably about 13 of them, yet to be finalised, sit in spinal services, and some of those have been the late flipovers from neurosurgery as we worked through that enormous backlog of neurosurgery that was apparent to us once we came out of the summer months. So, and then a smattering of odd ones, which are some in relation to patient choice who chose not to want to come and have their surgeries in March across a couple of other specialties. So teams have done a fantastic job. What I would say it doesn't end really at the 31st of March, because we need to eradicate 78 waiters from our scorecard and our narrative, really. So we've got to continue to work hard as we make things workable. You know, we'll have another circa 170 patients on top of that, 23 patients that we need to get seen and treated before the end of April to get to 0. So we continue in our ambition to do so, but we had in our tier 1 conversations reported to region and national that we expected to land between 30 and 40. So we have done better than we had discussed. On 65-week waits, against that 800, we will be down to probably maybe slightly less than 800. And that stands us in really good stead as we look forward in part 2 to our annual plan submission and the clearance of 65-week waiters by September. So that's a good position in which to start the year. And as I said, better than we had predicted. And on 52-week waits, that will probably land at just less than 8,000, which again is better than the plan. And again, a reminder, those 8,052-week waiters will be 65-week waiters by September. So that's the kind of size of the challenge as we go into this year. But teams have done a really, really good job in managing all of that demand on the back of the challenges that we've had over the course of this year. When we look at cancer, our national ask was to be below 222. for cancer performance in terms of the patients waiting beyond 62 days. We set ourselves a challenge of getting below that to 175, and then we've had all of the issues with 10 site closures and a 30 to 40% increase in referrals across dermatology. We look, as we stand today, to come in at about 257, which again, fantastic position to report. We had committed to GM that we would try to get to 285, so we've bettered that position. That means that the GM overall position will be better as a result of the performance that we have delivered. And we will continue to track those basal cell carcinomas. I know Aziz was concerned about that, so we've got a team coming to Quality and Performance Committee next month just to give that assurance that the basal cell carcinomas are not being disadvantaged by stepping off the 62-day tracking. We will deliver the faster diagnosis standard, so the standard was 75% by the end of March. And again, the work done in dermatology, and in particular in teledermatology, will likely be that once validated will come in at about 76, 77%. So again, phenomenal efforts by the teams. And then finally on urgent care, we were asked to do a revised plan of 73% nationally. We thought we could see a way to get to 70%. We look like we will have delivered 67.2% at the end of this month. So not quite a number, well, it is a number with a 7 in, which was what we kept being asked to do, a number with a 7 in, not the leading number though. So we've most certainly got work to do as we step into this year to get that urgent care performance above 70%. What I would say is that when I look at our type 1 performance, so back to the conversations that we've had earlier today, and you'll have seen the news in the press about patients waiting a long time in the type 1 emergency department. Our type 1 performance is certainly one of the best in GM. So we are doing a good job on type 1 performance, not where we need to be, but certainly some of the organisations that may have delivered slightly better than us on urgent care. There's probably only 2 in Manchester that have done better than us. Have a lot of type 3 performance and wish to support their position. But most certainly we've got work to do on urgent care as we step into this year, and also in the context of the conversations that we'll have around money. You know, we haven't quite entered that discussion of what we spend on urgent care. It's a lot, actually. We focus a lot on LLPs and planned care. Spend considerably more resources in delivering non-elective care. So we need to think about those opportunities, I think, from some discussions that we've had this morning. So overall, in terms of access for our population, we certainly have improved the lives of some of our populations that we serve by getting them in and treated, and hopefully making a difference to symptoms and getting them back to their normal activities of daily living. So that's pleasing for us. Overall, in terms of the scorecard, I think you can see, I just want to go to paediatric speech and language. It was a really big challenge for us, and that, you know, actually wanting children to start life and start school life in particular with the best start possible, you can see that challenge, you know, is really coming down. It will continue to come down, I believe, over the course of this year with the work that the teams have done. And there is a focus now in the Rochdale system on what else do we need to do. So one for us to watch as we step into next year, I would say. I think some pleasing things on some of our clinical outcomes, HSMR, maternity, and certainly on our staff, where we've had a good discussion about that this year. I would say sickness absence, while we've got to where we need to be, actually has a massive impact on our performance and on our money. So we've got a challenge next year. It's been flat largely for the last few months, and we've got a challenge next year with improving that. And having been on call all Easter weekend and dealt with the number of our junior medical staff that ran in sick over the course of this weekend, I would suggest we've got a lot of work to do on working with our junior doctors and our doctors in training on sickness absence management and understanding about how we might keep them happy and healthy and well in work. And I'll pause there.
Well, just absolutely astonishing when you think where we started off and how many, well, the proverbial rabbits have been pulled out of the hat. It's just astonishing what's been done. And although everything is not where we would want it to be, we're in a very good position to start next year. Mrs. Drinkwater.
So support that about the progress that we've made. I wanted to come in relation to your last comment about junior doctors and people. So last Thursday I attended the Junior Doctor Forum, which was a discussion that we'd had at People and Education, and we've made a commitment that I and Aziz would attend at least one Junior Doctor Forum this year. So I know Aziz is going in June. And I heard the concerns. Well, firstly, it was very, the attendance was very low, but it was the day before a bank holiday started. So it's a bank holiday weekend and a high holiday period. There were no senior managers or execs who could attend, but it was more about what I heard about absence gaps, concerns, how much effort has to go into covering those gaps, and even to the point of when we're out there looking for, we're putting out the notices to cover those gaps, and we're putting them out a couple of weeks before, and this is not sickness absence but planned absence. We get a very last minute response from locums who might say, I can cover, but it has to be at this rate. So they're gaming the system, and the person that was reporting it said there's a known individual who just knows that if they leave it till the last minute, because we are so desperate, the manager in charge then will say, I'll just have to go with this. So we have got a lot of work to do, an awful lot of work to do, and I just wanted to share that I was going to raise it today, and you've given me an opportunity to raise it, which I think we have to do some work in that space.
Well, this is so great performance, and obviously the teams are on board with those national targets to pull it out the bag in the way they have. Just separately, I wanted to ask about continuous flow, and do we use that in this organisation? Do we use it across the organisation?
Yeah, so we that was initially rolled out at Oldham. It is really well embedded in Oldham, and a key part of how they've managed to deliver some of the performance that they have in the latter half of this year. We did that sharing at the senior management team across the other care organisations. It's fair to say there was a slow uptake of continuous flow in Salford and Bury. But as we moved into Q4 and the imperative to really drive that performance improvement, we should have gone live with continuous flow in Bury last week, but they had norovirus across a number of wards, and it didn't feel right. I had a discussion with the urgent care leads on Thursday. Didn't feel right to start to roll out on the back of norovirus, but going into a bank holiday weekend didn't feel like the safest time for a go live. So we will pick that up again in April, but it's another thing that we've got in our bag yet. So, yeah. You know, if we think about, 67.2%, what else have we got to do? We didn't manage to expand the SDEC offer in Salford either. So we've got other things that we can do in April. that will drive that continuous improvement. Salford has gone live, I would say, in a sort of soft way in terms of continuous flow. So perhaps not what I describe as the full part version that is in Oldham necessarily, but they are continuing to work on that cycles and the engagement across the wards and different areas. So the rollout has been slow, but we have rolled out, and it is part of the plans for next year. And we've shared some of that learning across Greater Manchester as well. So Oldham was the first care organisation in Greater Manchester, and they have presented that at the Urgent Care Board in June.
Okay. It would be useful to have feedback then on the timetable for rollout and any other initiatives.
I think when we did the annual planning day, we had, an ask had been made to, when we bring the final plans for our annual plan submission, to really bring alongside that an urgent care improvement plan. So we had a first discussion about that at Quality and Performance Committee this month. And we will take that through Quality and Performance Committee. A bit of it is top down, bottom up work that we are doing, and I've got a conversation with the 4 Localities Partnership on Friday about that plan, so we can see actually what are the big things that need NCA-wide support, what are the things that a care organisation just get on and do it because we've tested it and we know it's live, and what are the things that actually need to be very locality specific. So we will bring that plan and try to apply a logic model of what's the percentage contribution of that thing to the performance. Not an exact science, but we'll try and give that a go.
Okay, thanks.
Thank you. Miriam.
Thank you. I had a couple of comments and maybe a couple of questions. So I know we discussed it at the last meeting around what we bring to the board, how we make sure we have the right information, the critical information in order for us to make decisions. And I guess my reflection is this for me is our vision, mission, and making sure that we are driving in that direction. And I think it would be good to start with this and then deep dive into the areas where we need to focus. So I don't know how far, I know there's a review on how we do that, but I don't know how far we are from kind of revamping all of that. But it would have been good to start here and then deep dive in some of the areas. An example that I pick out is I know we went through the discharge front runner program, but then I look on the left hand side and actually we have the children waiting, and those numbers are not changing much. And I would have wanted to understand a little bit more about that. So I think maybe it's something to think about, maybe for next board meeting, that we start with the vision, the mission, and then deep dive into the different areas. So, that's specific on that one. I guess I had a couple of key questions. The first one is, I think in the summary, you've talked about all the areas except population health. Just interested to know, I know we discussed it before and we had some challenges there, so I'm just interested to know where we are in terms of population health. And then I think we also had before a comparison of how we're doing versus kind of the benchmark across NHS England. And it would be good to understand that as well in some of these KPIs, to say we might be driving to our target, but actually is our target good enough and how do we compare to others? So we could cover those maybe in next forums.
So whether we could pick up the conversation about population health in part 2 when we look at our objectives for next year and what we might be able to do. I certainly see speech and language performance improvements part of improving population health, that giving children and young people a good start. I think in terms of where we benchmark against some of these things, we can start to make that feature of the new scorecard. I think Maria, you one of the non-executives that have come forward to work with Alex on the look and feel of the new scorecard, so that might be something we can pick up with him. What I would say is on the 78-week position, as we went into March, we remain one of the most challenged organisations in the country, but actually the distance between ourselves in terms of backlog numbers and the most challenged was quite considerable. So some of the most challenged in the 500s region. So I think we managed to go 24th. GN overall, So this is and this is a conversation we might want to take into part 2, you know, when we talk about how do we close the financial gap and what does that mean in terms of delivering the performance and what can you grow back on in terms of the performance. So for Greater Manchester ICB, if you look at 52-week waiters, the volume of 52-week waiters, so bearing in mind 52-week waiters become 65-week waiters in September, we are one of the most challenged ICBs in the country. So when you think about health equity, access to targets, you know, we are at the back end of that. And I think we rank at 6th highest in that 52-week backlog numbers of 8,000 that I stated earlier. And MFT probably the 2nd highest in the country. So Greater Manchester, rolling back on any planned care performance will have a big impact when we compare about where we are nationally. And Greater Manchester 52-week backlog is twice as big as the nearest ICB, the next nearest ICB. So a little bit of context that we might want to take.
It'd be good to have that because we can always start on that, we can start to understand how we prioritize, because everything's important, but how we prioritize based on where we are in terms of our target, you know, our peers. And also I guess the connections for me, because I know we've gone through the financial review, but then I look at this and I'm trying to connect the pieces. I think we need to start at the top and then come back and see how the different pieces tie back to. So looking forward to working with you.
Yeah, let's pick some of those conversations up with Alex. I think those are good ones.
My other point was around the children. I think we don't have to answer it now, but maybe something to deep dive on next time.
Children's waiting times.
Thank you. And then finally, Pastor Shaw, and then we'll move on.
Thank you. Just really briefly, it's a further challenge the board has going back to skilled person and postpartum hemorrhage rates because we've seen a deterioration. Just mindful that we continue to keep our focus and maintain our focus on that area, bearing in mind the early conversations we had around what's happening in our weeks and conversations we've had about the whole pathway forward from those experience from antenatal care right through to postnatal care, what happens in between, how that impacts upon access and their ability to receive services in a timely way, hopefully reduce skilled based and other things that we get. I just wanted to note that. The other one, the urgent care performance, you have answered. So again, retaining our oversight of non-admitted patients and focusing on capacity around treating emergency care. I just wanted to come back to waste management because you mentioned that, didn't you, in the report. So a high rate of waste requiring alternative treatment. So why are we not able to dispose safely in the infectious waste? It seems that we're at odds with our policy on that matter. So can you update me on that?
Yeah, so some of those are behavioural issues, but some of them are actually really practical solutions about actually having different segregated waste bins in areas that don't have enough space for different segregated waste bins. So some of it is just practical solutions, but a lot of it is behavioural. It's a key part of our cost improvement efforts over the course of this year, sitting with our estates and facilities college, and we report on that through our weekly statement meetings. We have made an investment in this area, so we've made an invest to save decision in that we've got some waste officers, I'm going to call them, I'm sure that's not the right word, Craig will correct me, waste officers who we've done quite a bit of learning in Oldham and in Rochdale around educating staff, waste officers being out there, ensuring we've got all the right bins with all the right labels on, and staff understand that, and particularly that shift into tiger waste from clinical waste, which has a massive saving for us. So those waste officers have been approved through the Vacancy Control Panel. They are, I think they may be due in post in April. And this site in particular for segregation of waste is really particularly challenged. So we've taken the waste revolution, we described it, into Salford from this month with a view to really having a big drive in Salford, because there is an opportunity here at Stones.
Can we kind of say the progress will be, but it does have cost implications and it does have operational.
We're bringing the green plan to Q&P next month, and it's a key feature in the green plan reviews.
Thank you so much.
Thank you. So I think we've noted those really good improvements which will set us up in a good place for next year. And also colleagues have made some suggestions about what kind of information could be presented in the IPR. So given that, can we move on to the next item? And I'm going to suggest that that agenda item relating to sealed is deferred until next month, as there is some alteration needed in that paper before it comes back to the board. Given that that's acceptable, the final item is the information paper on last month's part 2 items, and those items are found on that paper for information. Any other business? No. Thank you. I am conscious of time, and we always seem to get to this point where we can't really say much about board performance and reflection, because it is an important part of the agenda and does build up to reviewing the effectiveness of how we work. But I'm afraid we really do need to defer that to next month. Date and time of next meeting is on the agenda, 1st of May. So we can close part 1. Thank you for your contributions. And can I suggest that we have a 3-minute break